my name is Dr. Miranda Goslin. I'm one of the veterinarians at Millbrook Equine, and I'm super excited to welcome you all to this year's Cavalcade Equine Repro Symposium. This is, I think we've put this event on maybe 4 or 5 times now, so I think we're pretty well versed at it. We're excited to be here in the VFW Hall in Red Hook. And today, hopefully, everybody will go home with some information that they can use that'll be practical and that they can apply to this breeding season. Or if anybody has questions, hopefully we can answer some of those, or maybe answer questions you didn't know you had. So I'm going to start off today. I'm the lucky winner who gets to get the whole thing going. And so I thought, because it's the morning and I want to make sure that everybody is well caffeinated today, that this would be an interactive experience. Okay, so I'm going to be talking about mare mythbusters. So this is a topic very near and dear to my heart, because I feel like every year as we start off the season, there's a whole bunch of questions that I get that I'm always like, I feel like I talked about this before. So here's an opportunity for me to throw down my soapbox, climb up on top and be like, okay, remember, these are all the things that we have thought to be true. The goal is that you will come out of this and you'll be like, oh yeah, now I've got all the answers. I know what's true and what's a myth. All right, so the rules of the presentation. Okay, I'm going to show you a slide and you're going to see a statement. And I want you to think about the statement on the slide. And I want you to think about whether you think the statement is a fact, whether it's true, or whether you think it's a myth, okay? Okay, so the statement is, pregnant mares need to be fed for 2. All right, so how many people got there? I mean, I'm gonna say that looks like it's pretty unanimous that most people think it's indeed a myth. So, it is not true that pregnant mares need to be fed for 2. The whole concept behind this is pregnant mares do not need twice as many calories when they're pregnant. Lactating mares do need much more calories, but if you are feeding your pregnant mares good quality forage as well as water, and you're providing her with balanced vitamins and minerals, and you're helping to maintain her at the body condition score that is optimal, which is that 5 to 6, then you are doing the right thing. So far we're doing well. It seems like everybody's keeping score, whether they got that answer right. So that was a myth. Pregnant mares do not need to be fed for 2. Does anybody have any questions about this? Moving on to our next one. Only barren mares should be under lights. So when we put our barren mares under lights in November, that's the correct population of mares to be under lights. Is there? You guys are doing pretty well. Maybe you could have given this presentation. So yes, early foaling pregnant mares. We recommend the early foaling pregnant mares are under lights. They go under lights about the time of Thanksgiving or early December. And this is like your population of mares that are foaling in January, February. Some people even do like early March, but it helps to prevent those foaling mares from shutting down. So early foaling mares have the tendency, if they're not put under lights, either in their stall or using an equiloom, that they can shut down and you will have a hard time getting them to cycle. Okay, our next statement is every pregnancy should be evaluated prior to starting Altrenagest. Every pregnancy. This is a fact. Every mare is a unique individual, and not all mares and not all pregnancies are the appropriate patient or case to be treated with Altrenagest. And so the reason why I say this is that some mares, if they are immunocompromised at all, they may not be the best choice for Altrenagest, because Altrenagest can cause some degree of immunocompromise in the uterine environment. Additionally, there is evidence to show that it can result in a lower progesterone level in the mare until secondary CLs form. So I want to say that while this drug is a safe drug and we use it commonly, there are cases where maybe it's not an appropriate choice. So talk to your veterinarian about whether the mare that you're thinking about starting on Altrenagest or Regimate is a good candidate, an appropriate candidate for it. It is indeed a fact. Endocrine issues and obesity do affect the fertility of the mare. So I highly recommend that if you are considering breeding a mare that you are suspicious of any endocrine issues, that would be our PPID or Cushing's or insulin resistance, that you're testing for those things before you're interested in breeding the mare. And the concept would be that we would get all of that regulated well beforehand, and that all of that is ready to go by the time we start thinking about breeding her, because it will impact the fertility. All right, our next statement. This is a good one. Full diarrhea is evidence that a mare is in heat. So when a foal in the first 2 weeks of life develops diarrhea, that is caused by the mare being in heat, or the mare being in heat is due to the foal having diarrhea. They are directly related. And that I know that the mare's in heat because the foal has diarrhea. So it is a myth. What happens at this time is that the foal is developing the normal flora. And so there is a period of time where the foal will have some diarrhea and scours, but it's coincidental. It is not caused by the mare being in heat, nor is the mare being in heat caused by the foal having diarrhea. So when a foal has diarrhea, to me, that means I need to treat the foal. It doesn't mean I need to breed the mare. Those things happen about the same time, but they're not caused. It's not a causal relationship in either direction. Okay, our next statement. Mares can be short-cycled at any point in their cycle. And if a mare doesn't come into heat, it's because the drug didn't work. So if short-cycled, so I'm talking about the use of prostaglandin, either Estromate or Lutalice. Mare can be short-cycled at any point. All right, it is indeed a myth. And what I would say to you is it matters whether the mare is an appropriate candidate to be short-cycled, okay? So in order for a mare to be short-cycled, she has to have an active CL or corpus luteum, right? So additionally, if she has a secondary follicle sitting there, like a 40 millimeter follicle, she's going to break down that CL and she's going to zip right through and ovulate, and we're not going to see any signs of heat. Potentially, you're not going to see any signs of heat on ultrasound, and you're definitely not going to see any signs of heat with behavior in terms of teasing. So I would recommend in this situation that if you're thinking about short cycling a mare, I like to ultrasound the mare before I give the Estromate. And for me, I have a lot better success. I have to choose the right candidate, because if I just inject her with the drug, sometimes she won't respond, and it's because she's not the appropriate candidate. This is for our stallion people. Mares must be walked immediately after breeding or inseminating. We don't want them to urinate. It is a myth. So I want to remind everybody of the anatomy, which I think is really important. When a mare is inseminated, we pass the pipette into the vaginal vault through the cervix and deposit the semen into the uterine body, right? That's the goal, okay? And the same thing happens with the majority of the ejaculate from the stallion. It travels through the cervix and into the uterine body, okay? So there is some amount that ends up in the vaginal vault, and sometimes that ejaculate is utilized to reinforce breed the mare. But I would say the majority of it does go into the uterine body. And as you all know, when a mare urinates, the urine doesn't come from the uterus. It comes from the bladder through the urethra, right? So we know that she's probably not going to urinate out the semen, that it's going to be safely in the uterine body, and it is not likely to come out when she urinates, right? Next question or statement. Ovulation induction drugs work as soon as they are injected. So if I give a shot of deslorelin or HCG or historelin, it is working immediately. And that mare is, I better breed her or inseminate her right now because it's working. Yes, it is a myth. So our ovulation induction drugs take anywhere from 24 to 48 hours for them to work. And the way that we utilize those drugs is we try to time when the mare is going to be bred or when we're ideally going to AI her. And we count backwards and figure out when the appropriate time is for her to receive that ovulation induction drug. If you use it in such a way where you give the drug after she's AI'd, or if you don't trust FedEx, or if you are in a situation where you want to make sure, like you're driving in a snowstorm and you got to get to the shed and then you got to get back in a snowstorm, you're using that drug more as an insurance policy. And it's not wrong, but if you're utilizing the drug to get the mare to ovulate as close to insemination or as close to breeding as possible, then you'll give the drug before you're intending to breed the mare. So both ideas are fine. There's nothing wrong with them. I would just say that the purpose and the idea behind each way is different. Thank you, especially to our sponsors, to Platinum and to Merck and to Equiloom. Okay, so we got a couple questions. One is what is actually causing the full heat diarrhea in the foal? And so what happens during that period of time is the foal has to establish gut flora. So what you're seeing with the full heat diarrhea is it is the foal establishing that gut flora. It takes a little bit of the different the different aspects of that gut flora have to kind of normalize for that individual. And so that's why you see it in the foal. At one point in a mare's pregnancy, should she be started on Regimate if she's found to be a good candidate? And I think the answer to this is practitioner dependent. There are some practitioners who like to test a mare around 5 days post-OV, 5 to 7 days post-OV to see if the mare has a low progesterone, and they will supplement and use Altrenagest in that situation to help maintain the pregnancy. And then there are some people who will choose to just start it, but at least after 5 days of ovulation is when that would take place. And then if you have a mare that is experiencing a stressful situation, like she's had to go for colic surgery or any kind of injury, or just overall she's pregnant and now she's stressed, you might choose to put a mare in that on Altrenagest for that situation as well. So a mare that's maybe going to ship back from Kentucky, it's really common for mares to come back to us and be on Altrenagest or Regimate. Testing for endocrine issues, I'm trying to think. Yes, because we are talking about breeding the aged mare. So my guess is yes. But I will tell you that for me, I prefer, like if I know I'm going to breed a mare and she is an open mare, I'm going to test her for PPID and do an ACTH insulin in the fall before I start thinking about breeding her, because that for me in my hands is the most sensitive time, and I will catch those mares that are going to need treatment. If I'm testing later, say for example, I don't have the ability to test the mare until spring and she's just foaled or something like that, I'm going to use a TRH stim in that situation. So it is practitioner dependent on what people recommend, but in my hands, I find that unless I'm testing in the fall, the TRH stem is the best choice for identifying mares that have Cushing's. You're saying every pregnancy should be evaluated. However, many mares go on Altrenagest at 4 days before a pregnancy is evaluated. And I would say I would just encourage you to speak to your veterinarian about that. Like, again, it's a conversation. I think a lot of people automatically put mares on Altrenagest, But I would encourage you to talk to your veterinarian and decide if it is an appropriate choice. What test for Regimate do you recommend and when? I think I talked about that to check. You can check the progesterone, but again, Altrenagest is a useful drug in that situation because when you check a progesterone, the Altrenagest is not going to impact the results on your test. So I would say in that situation, you can recheck the progesterone level on a mare after you have started her on Regimate and see if her natural progesterone has come up, and that gives you the ability to take her off. So, can a mare with PPID carry full term? Yes, a mare with PPID can carry full term. And I would say but it's really important to make sure that you're treating the PPID.
Hi, everybody. My name is Dr. Lana King. I'm the resident specialist in reproduction with Millbrook Equine. And today we're going to be talking about breeding the aged mare, which is a topic that I love because I feel like half of our breeding population fits into this category at our clinic. So first, I think before we can have a meaningful discussion about this, we have to make a definition for what aged means. So how old is old? And I think a lot of people would be surprised to find out that that's a lot younger than they think. And that's because, of course, the mare's actual lifespan is much longer and they can still be in quite good health while their reproductive lifespan is coming to an end. So if we break mares up into groups or cohorts, we find that the most fertile group is going to be the 3 to 10-year-olds. And inside of that group, the maiden mares are going to be the most fertile of the bunch. And that's just because, maiden mares can have some congenital issues. That's quite rare. So for the most part, their reproductive tracts are functioning very well. The second most fertile group is going to be your foaling mares. And that's just because when we consider that group, we have to include mares that may have had foaling traumas or maybe had infections that they didn't clean up after foaling. But both groups are going to be considered quite fertile, with the vast majority of them getting in foal in the first cover, and then some of them taking a second cover. Once we get up to 15-year-old, that's when we start seeing a lot of age-related changes in the reproductive tract of these mares. And those changes accelerate each year that goes by. So by the time they're 20, it's getting quite difficult to get them in foal. Okay, so that means that once we reach the age of 15, it's really important to take every cycle as seriously as possible. And each year that goes by is important. So the more that we delay, the lower our chances are going to be. And then most mares are going to be shutting down their fertility at around 25 plus years of age. So I thought what we would do is we would just talk about the physiology of how the reproductive tract ages a little bit, and then we'll go through some interesting case studies so we can talk about, how we treat those things the best we can. So we'll start at ovaries. And we're just gonna dig into some physiology here for a second. What happens? So most mammals, as some of you probably have heard, are born with the full complement of oocytes that they're ever going to have in their lifespan. And then they're just kind of sitting there in the ovary waiting to be recruited into a cycle. So once that happens, the oocytes begin to develop into these primary and secondary follicles. And then they reach a stage where they're responsive to hormones. Okay, so they reach this preantral follicle stage, and then the FSH, or follicle stimulating hormone, produced in the brain of the mare, in the pituitary gland, that induces that oocyte and follicle to mature. And then it reaches a stage where it's fully ready to ovulate, and then it develops LH, or luteinizing hormone receptors, on it, and it's capable of ovulating. So each time the mare has a cycle, it's going to recruit a cohort of these follicles. And as you can imagine, eventually that pool of primary follicles gets depleted over the mare's lifespan. And so there's actually some work being done right now on determining if we can test a hormone called anti-Müllerian hormone to determine what that follicle or oocyte reserve is in the ovary. I think they're still working the kinks out on that, so we don't have it available yet. But eventually, at some point, we may be able to do a simple blood test and determine, hey, this mare has very few follicles or oocytes left, or, you know, this mare still has a longer reproductive lifespan left. So, the other thing I wanted to mention also is that these follicles are producing their own hormones, estrogen and some other things that are communicating with the mare's brain. And so the brain that's producing the FSH and the LH knows what the ovary is doing. So as those mares deplete those pools of oocytes, what happens is they produce less of their own hormones, right? There's less follicles, so there's less hormones communicating with the brain. So the brain knows there's not enough follicles on this cycle. So it produces more and more FSH. So we find in these older mares, they start to have very high levels of FSH. And at first that works. At first, that means that the ovary will respond. It'll recruit more of the primary follicles. And we'll see that those mares that are in the early stages of aging will have decreased length of their cycles, so 16 to 18 days often. And they'll, they'll often double ovulate as well. As they kind of continue on through the aging process, the cycles become longer and more irregular, so that elevated level of FSH stops being able, there's just not enough oocytes there, so it stops being able to recruit them. So we see that sometimes these cycles can be very long. I had one mare that we had to wait 30 days for her to cycle every time. So, and then the other thing that happens is the follicle stops producing enough LH receptors, and so it fails to ovulate more often. So we get more of these anovulatory hemorrhagic follicles that you can see in this picture here, which are very frustrating because they begin development normally. They look like a normal follicle, and usually all the time and expense has been spent on breeding these mares. And then a few days later, the follicle looks like this and it never ovulates in oocyte. And then finally, as these mares continue aging and they have no more reserve in their ovaries, they become senescent and they stop cycling altogether. So these are a set of ovaries that have become senescent. You can see here, they look like an anestrus set of ovaries. So in what they look like in winter when they're not doing anything. And then on the right, you can see an ultrasound. If you're having a hard time telling where the ovary is, sometimes I have trouble too. So that's the ovary there, which you really, it's hard to tell what it is because it has no follicles on it really at all. So in tandem with all of this depleting of oocytes, the other thing that happens in these aged mares is that they start to lose viability of the oocytes. So those oocytes are also themselves aging and becoming less and less able to produce an embryo. There's a couple of known causes why this happens. There's probably a lot of other things going on in the oocyte that we aren't aware of. But what we do know is one thing is that the chromosomes fail to align properly. So we all have two sets of chromosomes. Remember that the oocyte is only half of the embryo, and so it has to get rid of an excess amount of genetic material before it's ready to start making an embryo, make room for the sperm set of chromosome also. And so during maturation in the follicle, and then just after fertilization, it undergoes 2 times where it sheds extra chromosomal material. And so this image on the top is showing you on the left, 2 is what a healthy chromosome alignment and separation should look like. And then on the right, you can see that it's very disorganized. The chromosomes are the blue in the middle, and they're kind of scattered all over the place. So what happens is when they go to separate, the wrong amount of chromosomes goes to each side, and then the egg can't survive with the wrong amount of chromosomes. Down at the bottom, you can see a healthy oocyte that has extruded its genetic material successfully. That's what those polar bodies are there. And then there's also alterations in the metabolism. So they just they don't survive very well. And they don't have the necessary metabolism to continue through cleavage and embryo production. All right, so that's what happens in the ovary. If you look, so the mares don't have very often problems with their oviduct, and when they do, they're not usually age-related. So we'll skip over the oviduct and go straight to the uterus, which is probably the site where the majority of the problems arise. So there's a significant amount of age-related change that happens in the mare's uterus, in the uterine lining, and we call it endometriosis, which is not to be confused with endometriosis, which is a human condition that's totally different. But in this endometriosis, what happens is we get a lot of fibrosis. Okay, fibrosis is another word for scar tissue that forms around the glands and in the kind of stroma, so the tissue of the endometrial lining. We get angiosis or angiofibrosis, which is scarring around the blood vessels, lymphatic dilation, and then cysts. Cysts are not technically part of this process, but they're usually an indication that endometriosis is happening. So we'll talk about cysts as well. So we'll talk about the glands first. The glands are very important because they provide all the nourishment to the developing embryo. The equine embryo, it doesn't form a placenta until extremely late compared to most species. So we're not getting placental development until day 40. And so that means from the time that the embryo arrives in the uterus until day 40, it's just relying on these secretions from the uterus that it has to absorb through diffusion through its membranes. So here on the right, you can see an endoscopic view of an embryo inside of a uterus. And those kind of white dots that are attached to it are proteins that are being secreted by the uterine glands. We call it uterine milk. The best way to evaluate these glands is through a biopsy of the uterus. So a lot of times I'll recommend a biopsy for these 15 plus mares so we can get an idea of what's happening. These first two images are pictures from a healthy uterus of a younger mare. And this is just to show you that on the right, you have an estrus, and on the left, you have a diestrus uterus. The glands are the purple circles. Those are the cells lining the glands. And you can see that the density really increases in diestrus, which makes sense, right? Because in estrus, when the mare is in heat, the glands aren't really needed. But then if the heat cycle was successful and that mare becomes pregnant, then those glands need to start producing a lot of uterine milk for the pregnancy. And so they are responsive to the progesterone hormones. They increase in density. And also the edema in the uterus decreases, which kind of clusters them together. This is a mare that's just beginning to have signs of endometriosis. And you can see that her diestrus uterus looks more like the estrus uterus in a healthy mare. So it's not responding to progesterone very well. It's not increasing gland density, and it's going to be harder for an embryo to survive in that environment without enough uterine milk being made. This is a mare that has severe endometritis, and you can see some changes in the glands. So first of all, you can see on the picture on the left that they're nesting. We call it nesting when there's so much scar tissue around them that they clump up together. And then the image on the right is a close-up of the nest. So you can see that all the uterine milk inside of the glands is inspissated, and the glands have dilated because they can't secrete into the uterine lumen. And I don't know if you can appreciate that, but all of the tissue, all that purple tissue you see around the nests is all scar tissue around it. All right, the next thing that happens is angiosclerosis, angiofibrosis. They're all kind of the same thing. These are pictures of the artery and vein that go to the uterus. These kind of changes are happening with all of the vessels throughout the uterus, but this one you can really see the healthy one on the right. That's what a healthy artery and vein should look like. And then the one on the left, you can see that it has lots of scar tissue. And so what happens is these vessels really can't supply the uterus with enough oxygen and blood and nutrients to do their jobs. And so we see, as a result of that, lots of early embryonic death. We also see, as a result of that, glandular fibrosis from just the glands not getting enough oxygen. Another way we can evaluate it, besides the histopathology, it can actually be seen on an endoscope. So if we do a hysteroscopy, put an endoscope inside of the uterus, at the top you can see a very healthy endometrium, it's pink. And then the bottom first picture is showing an unhealthy uterus suffering from endometriosis. I don't know if you can appreciate, but you can see white spidery lines. And that's the scar tissue that is affecting the blood vessels just below the surface. And then we can also use a narrow band hysteroscopy. So we change the light source a little bit for the pictures on the right. Oh, they're not coming out very well on the screen. Sorry about that. But you can see the blood vessels really well under the surface in this narrow band imaging. You can see there's lots of blood vessels in the healthy endometrium, and then not so much in the unhealthy one. The other thing we look at the biopsy for is lymphatic dilation. It's very hard to see on the histopath, so I didn't put up any images of that. But what you do see on the ultrasound often with these mares is a lot of excessive edema. A lot of these mares will have a little bit of fluid in estrus that doesn't look, it's usually black and it doesn't look that bad, but it just won't go away no matter how much oxytocin you give her. On palpation, your vet might describe it as like a baggy, pendulous or doughy uterus. It doesn't have much tone. And then when these mares are bred, they tend to have terrible problems with fluid accumulation because the lymphatic drainage and the myometrial contractility just isn't there to get rid of the fluid. They also tend not to respond as well to oxytocin as a normal mare would. So it makes it a very frustrating situation. So as I mentioned, I really like doing biopsies on these aged mares. I think it gives us a lot of information. Once we get the biopsy back, it can kind of set our expectations. We can be realistic about what to expect from these mares. It's very easy to do. You can see in the image, we're just taking a very small piece of tissue. Doesn't affect the mare's fertility at all. And then they will look at all of these changes and also inflammatory changes and give that mare a score. So a grade 1 biopsy gives the mare an 80% chance of having a live foal. A grade 2A is 50 to 80% chance. Grade 2B is 10 to 50, and grade 3 is less than 10. So I usually tell people who have a grade 3 biopsy that mare is probably it's probably not worth trying to breed her and have at least not to carry her own foal. All right, so cysts in themselves, they can cause problems, but usually they don't. They bother us because they make it difficult to tell what a pregnancy is on an ultrasound, especially if there's a lot of them, or sometimes they have a perfectly round shape, just like an embryo would. So they're more annoying than anything, but they also indicate that there's probably a fair degree of endometriosis going on. They basically just represent outpouchings or dilations of lymphatics. And so here's some hysteroscopic views of what they look like. And then the third image is what it looks like on an ultrasound. The one exception to them causing a problem is if they physically obstruct an area of importance in the uterus. Okay, so I've starred some of those in the diagram of the uterus there. So the red star is right in front of the oviductal opening. So that's where the embryo needs to come out. And I have had one case where it was blocking that and preventing the oocyte or the embryo from getting to the uterus. But more commonly, the major problem I see with them is if they form very large cysts in the uterine bifurcation where the green star is, that's right where the embryo needs to fix. And it fixes at around day 17. Remember I said that they don't form a placenta until day 40. So they're getting all their nutrients through diffusion, but they're butted right up against a cyst. And if they have a cyst that's usually, I would say, around 2.5 centimeters or bigger, they're really interfering with that embryo's ability to survive. And most of the time when I see a case like this one that I've shown here on the right, that green arrow is showing the embryo proper. And then the black area around it is all the yolk sac of the embryo. It's sitting right against a cyst. And usually when you come back, you know, they're usually lost before day 40, I would say, in those cases. All right, and then finally the cervix. The cervix, okay, the picture on the right is a cross section through the cervix. You can see that it's mostly just soft tissue. It's a muscular ring, and it has to be able to relax in estrus and then close in diestrus. So in estrus, its job is to be open so that during intromission, the stallion's penis flares, it pushes the cervix open, and then the ejaculate is deposited directly into the uterus. Then it also needs to stay open long enough so that when that mare gets inflammation from the breeding, which is a normal physiological response, then that fluid needs to be able to come back out. And then it needs to be able to close so that nothing, bacteria or anything, can't get into the uterus while the mare is pregnant. In mares that have had foals, that's usually not a problem. They retain that ability to do that long into their life. But in mares that have never had foals by the time they're, well, certainly by the time they're 15 and sometimes younger, the muscular ring and soft tissue develops scar tissue and becomes fibrotic, and then it won't open. And so we tend to see that these mares get a lot of fluid retention. And it can be quite a struggle to deal with. They're predisposed to infection and all those things. So ideally, if you have a mare that you'd like to be a brood mare, she should carry a foal herself before the age of 10, and then periodically after that. So we have a lot of mares that we see for repeated embryo transfer, and we usually advise that every once in a while she carries her own foal to term so that the cervix stays healthy. And then we'll talk a bit about the endocrine system. Since this is a discussion about the aging mare, I'm only talking about Cushing's. I know there was a question about equine metabolic disease, so we could take that up in the panel later. But Cushing's is an age-related change. It affects 25% of all horses over 15. And every year that passes after that, they're at an increased risk for developing it. It's caused by a pituitary tumor in the brain. It produces pro-opiomelanocortin, and that hormone is involved in seasonality. Okay, so that's why these mares get so hairy, because their brain is telling them it's winter and it's time to shut down, which is one of the cardinal signs of Cushing's, okay, that they get hirsutism or hairy. And so seasonality is very involved in a mare's cycle as well. And so if we have derangements in seasonality, we're going to have derangements in cycling and ovulation and follicular development and all of those things. The other thing that it does is it depresses their immune system. And so it makes them have an increased susceptibility to uterine infections. So this is a cytology from a mare with Cushing's. You can see that there's neutrophils here. Yeah, all these neutrophils. So she has pretty bad uterine infection. I would say that a lot of the cases that I've seen that have yeast infections usually end up being Cushing's mares, just because their immune system is really poor. So I don't think in the case study that I put in a Cushing's mare, but it's relatively easy to treat. We put these mares on pergolide, and then we take them off when it's foaling time so that they can lactate, because the pergolide does affect their ability to lactate. But most mares will respond pretty well to that. All right, so we'll do some case studies, which is more interesting. Okay, the first case study, 21-year-old quarter horse mare. She had several foals early in her teens. So 21, remember, is getting pretty old for a brood mare. She had embryo transfer attempted 3 times in the previous season. 2 embryos were recovered, but none of them resulted in pregnancies. And her biopsy is a grade 2B. So does anyone have any thoughts on what they would do for treatment on this mare? I'll tell you the answer. So the first thing we would do is I would put her on supplements. I'm going to give a shout out to Platinum over here, the reproductive care. They've actually done the studies. They've produced some data to show that their supplement with omega-3s and antioxidants improves the viability of the oocytes that those mares are producing. And that's because it's involved in the metabolism of those oocytes. So in the data that they produced, they were able to show that 58% of embryos in older mares developed. Okay, so this is in an ICSI situation. So they were being developed in vitro. That 58% of them developed into embryos versus 15 to 21% in mares that had not been on the supplement that were in that age group. So first I would put her on that, improve the viability of the oocytes. And then I would probably recommend transvaginal oocyte aspiration, where we actually remove the oocytes from her follicles on her ovary and then produce embryos in vitro. And I'm going to show you how that's done in a second. But the reason for that is, first of all, her biopsy is poor. So I think that she's going to have a hard time carrying an embryo anyway. And also we know that her embryos didn't develop very well, the ones that she did produce. So I think for very much older mares, TVA really improves their odds of being able to produce. So this is a video of how ICSI works. The sperm is in this injection pipette here. So they're injecting the sperm directly into the embryo. Kind of got cut off there, but and so that way that bypasses all of the mare's reproductive tract, and you don't have to worry about the health of her uterus or any of those things. And then that embryo can be frozen and implanted into a recipient mare at any time. So for this mare, they actually ended up doing multiple TVA cycles, and they produced a number of embryos, which is also, you know, when you're talking about a mare that's 21, she doesn't have that many cycles left to go. And so if you wanted to produce more than one foal, this really improves the chances of being able to do that as well. Oh, now I'm stuck. Okay. Okay, the second case, 16-year-old thoroughbred. So she has to carry her own foal. So embryos and ICSI are an option for her. She's had 8 foals with 5 consecutive pregnancies. On her last breeding, the embryo was very small at the 14-day check, and then it was lost at the 28-day check, and then she was not able to get back in full. On the ultrasound, so this is an image of her tiny embryo. Looks like that embryo is probably less than 1 centimeter, and at 14 days, it should be more like 1.5 centimeters. Very small. And then these are some of the cysts that she had. Her biopsy was a low grade 2B with nesting and inspissated glands. So what do you guys think you want to do with her? What's that? Yeah. So first, we'll remove the cysts. There's a couple of ways of doing that. I don't know what happened with this picture. Okay, well, this is an image showing that we can remove the cysts with a laser. So we just, through the endoscope, we pass a laser and burn the little holes into the cyst until it deflates. There was a picture here, a cyst that was removed by a cystotome. So this instrument here, it has a wire. You pass it in and snare the cyst, and you just cut it off, basically. So removing the cysts, and then she had a poor biopsy with inspissated glands. So there's a few different things we can do to kind of remove that glandular material. DMSO lavages and kerosene lavages are 2 of the things that have been used for that purpose. Kerosene is interesting because early in my career, it was into the uterus, but since then there's been a few studies that have shown that it's improved the appearance of the uterine biopsy, and that a lot of mares that have been treated with kerosene have gone on to have foals. So it's something that we're starting to use a lot more of now. This is the lavage. So we infuse it into the uterus, and then we lavage that out several days in a row. This is the first lavage that we did on one mare, and you could see the kerosene all floating on the top there, and that the fluid that we recovered from the uterus was very cloudy. So it caused a lot of inflammation in her uterus, but that inflammation is helping to clear all the junk that's in her uterus, basically. And then in order to address the artery or vessel problem, we can also try and improve uterine perfusion with things like aspirin or pentoxifylline. And then most of these older mares go on Regimate. And the idea is that hopefully with extra progestins, we can stimulate those glands to increase their density and do their job a little bit better. Case study 3. The 15-year-old saddlebred mare. Anybody have any thoughts on this mare? She's had a bunch of foals, and every year this problem gets worse. And now she's been presented for breeding at 30 days. So anybody have any idea what kind of problems we might run into with this mare? Other than the fact that she looks horrible. All right. So by the way, I'm going to point out that not every mare is going to look this terrible, but they still may have these following problems we're going to talk about. So as the abdomen sort of drops and sinks and the pelvis tilts forward, as these mares get older, they start to have this conformation where they have a shelf over their pelvis. And unfortunately, what happens is since their anus is located behind that, as they defecate, some of the manure goes into the vagina and contaminates the uterus, and they tend to get bacterial infections all the time. Also, this mare was so severe that the urethra was also pulled forward. And so that means that when she urinates, the urine refluxes into the back of her vagina and goes into her uterus as well. So no surprise, this mare had a secondary bacterial infection. The biopsy was declined in this case because they decided that they were going to try to breed her regardless of what the biopsy said. So I think that's fair. But here's a picture of her cytology. You can see the neutrophils where the arrows are. She actually, I would have expected it to look worse, but there you go. 2 minutes, okay. All right, so the breeding plan for her is to improve the body condition score. Sometimes that can help with the perineal conformation, improve things a little bit. I don't think it's going to cut it for this mare. So we put a Caslix in that will sew up the top part of her vulva so the manure doesn't have access to the vagina. And then she was urethral extension. So the urethral opening is here where the arrow is, all the way back there. And a urethral extension basically takes the sides of the vagina and folds them up around the urethra so that it creates a tube that the urine can then like flow outwards instead of backwards. And that keeps the urine from going into the vagina and uterus. And then we flushed her. This is her flush that has urine and cloudy neutrophil stuff and little bits of her endometrium in the bottom. She was also given Settle. So Settle helps with streptococcus infections. It's an immune stimulant. And then she was scheduled for breeding rest for the rest of the year. And we're going to try and breed her again next year. Then case study 4 is your classic old maiden mare. Okay, 17-year-old warm blood mare. She's never had a foal. She was bred twice. She always has a tremendous amount of fluid when she's checked for ovulation. And of course, not pregnant on the 14-day exam. So the old maiden mare syndrome is kind of a combination of age-related changes that happen together in one mare, fibrotic cervix being the most important of those, and then the uterine fluid accumulation as a consequence of the cervix, and then they often have some degree of endometriosis as well. So to breed her, really important to have strict hygiene. So she's extremely susceptible to uterine infections. So we have to treat it almost like it's a surgery every time we go in and out of the vagina. Only breeding once. So we're really careful with our timing and using ovulation agents because every time we put semen in there, we're going to create more fluid. So we only want to breed her once. PRP is very useful in these mares. I think it helps mares that have poor lymphatic clearance, kind of tones everything up. And so that's something that we would do just before breeding, in the day before breeding. And then dilation of the cervix. So we can do that either manually. There are some people who advocate for using creams that are supposed to help relax muscle applying them directly to the cervix. I haven't had a lot of success in my hands doing that, so I find manual dilation of the cervix to be more useful. And then lavaging as soon as we have the opportunity. So 6 hours after breeding, we're lavaging those mares. This is a lavage from that mare. And I lavage until it comes basically crystal clean because she's not really able to get anything out of her uterus on her own. Then I'll check for fluid again the next day. And of course, she's going to get lots and lots of oxytocin. All right. Can everybody hear me in the back? Okay. My name is Lauren Pash. I'm a theory-genologist at Rhinebeck Equine. We are going to talk briefly about stallions today. The goal of this talk is not to go over pathology or abnormal or problematic conditions, but just to talk a little bit about the things that I think get overlooked in terms of stallion anatomy and physiology. And hopefully understanding sort of the process that's happening behind the scenes will make everybody a little bit more knowledgeable, whether you work with stallions every day. They are part of breeding no matter what. So we will briefly just go over anatomy. We will talk about the reproductive tract as a whole, a little bit about the accessory sex glands, specifically penis and testicle anatomy, and then an overview of the physiology of those topics as well. And then we'll just talk a little bit about breeding doses and how that factors in. So to start out, going over anatomy. So the picture on the far side is a removed reproductive tract, and then we have the schematic on the other side. So normally what we're seeing in a live stallion that we're looking at is sometimes the penis or part of it and the testicles, but there's a whole lot more going on inside. We will go over this bit by bit, but just to draw your attention to a few structures. So we have the urinary bladder here, and these little snaky guys laying on top of them are one of the more critical accessory sex glands, or more relevant, I should say. So these are the ampulla. We'll talk about them a little more, but you can see these structures labeled DD that are connecting the testes to the ampulla, and then it's going to go all the way through here to the urethra and then through the penis. We also have some anatomy that is going to be internal that we can't see unless we're ultrasounding the stallion, and then we have the external genitalia that we're all used to seeing in our breeding stallions. So the accessory sex glands, I think get overlooked a lot. They are important in that they produce all of these secretions that contribute to semen. So semen is not just sperm. It's going to have seminal plasma, and a lot of that is coming from the accessory sex glands. These are testosterone dependent in order to be fully functional. So they're still present in geldings, but they're going to be much smaller and inactive. So we have the ampulla, which are blue in this picture here. And these are, if we're going to see pathology in an accessory sex gland in the stallion, it's going to be the ampulla. They're these little narrow structures that, as I mentioned, basically connect the testes to the urethra. And in certain cases, they can become blocked. We have the seminal vesicles, and these are the red guys here. Again, similar function of all of these structures, but they're going to produce secretions that add to the ejaculate. We have the prostate. So it's this bilobed structure kind of with a bridge in between and the stallion. And then the Cowper's glands, usually call them caudal on a stallion. And these are some real-life pictures of removed reproductive tracts showing the accessory sex glands. The anatomy of these structures is rarely something relevant on the day-to-day. It's important when we have a problem and we want to figure out where the problem is. This is part of the entire reproductive tract that we should examine. And then also for doing a breeding soundness exam. I'll routinely ultrasound these for any abnormalities.
but you can see them here. And then again, these string beans here, the ampullae, seminal vesicles, oops, prostate right behind that. And then again, the same thing down here, the ampullae, the vesicles, prostate, and then we have the bulbal urethral glands back here. Talk a little bit about penile anatomy. So this is a cross-section through the free portion of the penis. So when you have a fully extended penis, we're looking at sort of the distal-most half of that. And what I really want to draw your attention to is how much erectile tissue there is. So that's the tissue that is supravascular. It loves to bleed, but it also is going to become engorged. And that's a big part of what allows the stallion to have an erection and breed. But there's two types of erectile tissue that we see in the penis. The corpus spongiosum is just going to be kind of in a little tube surrounding the urethra. And then up here, the vast majority of the erectile tissue is the corpus cavernosum. Moving on to the testis. There's a few practical divisions that we can make in terms of testicular anatomy. So that would be the testis itself, the epididymis, and then the spermatic cord. So the testis itself, just in case we aren't sure, this guy here, or in this actual picture, is almost entirely made up of seminiferous tubules, and we're going to talk about that more later. But that's the bulk of what that actual testis portion of the structure is. The epididymis is this elongated structure that kind of runs from around the top and inside, so in a protected area of the testicle, and touchy. So the epididymis is similar to the accessory sex glands that I just mentioned. It's going to produce a lot of secretions that add different qualities to the semen, make it compatible with fertilization. So sperm is going to move from the testis where it's produced into the head of the epididymis, and then the tail, and then the body, and then the tail. From the tail of the epididymis, so you can see in our diagram here, testis, epididymis, and then here testis, epididymis, kind of running around the top of it. And then the spermatic cord. So, before we move on to that, one more thing about the epididymis. Sperm that are in the tail of the epididymis, so that's the last portion that is going to pass through, are actually capable of fertilization. It's beyond the scope of this talk today, but we can actually harvest sperm from the epididymal tail and use that to breed mares and get pregnancies successfully. So that's usually either post-castration or post-mortem, but something to keep in mind. And so that's just the first instance that we see of, I guess, fully functional sperm is going to be in that epididymal tail. Anything in the head and body is not really going to be useful to us. And then the spermatic cord. It connects the testis to the body, and it has quite a few important structures in it. One of which is going to be the cremaster muscle. So this is actually an extension from some of the abdominal musculature, but that's the muscle that's going to be responsible for raising and lowering the testis in response to temperature regulation. We also have a lot of vasculature. In addition to sort of just blood flow as vessels always do, it's going to have a mechanism that's pretty much the testis, the cord, and the ductus deferens. And so the ductus deferens is where the sperm is going to travel as it makes its journey from the testis through the urethra. This is a recently castrated testicle, then it's just cut on the long axis, so you can see how non-exciting a normal testicle should look. I have an ultrasound image of one later too, but a normal testis is going to be really grossly, it's going to be kind of brown and homogeneous. It should bulge on the cut section, but you don't want to see a lot of irregularities, areas of fibrosis. It should be uniform and boring. So there are two main functions of the testis. One is sperm production, and the other is steroid production. And there's two different cell types that govern each of those purposes or tasks. So the seminiferous tubules, I mentioned that a lot. We'll talk more about it as we go on, but they're basically sperm factories. So the bigger the testis, the more seminiferous tubules you have, the more sperm you can produce. The cell type that is instrumental in sperm production are called Sertoli cells. They're the nurse cells, they're the helper cells. We have some images of them sitting sort of along the bottom of the seminiferous tubule, and they're really just supporting the entire process of spermatogenesis. These tubules are also going to contain basically sperm cells in all different stages of development. And then the other purpose, as I mentioned, is steroid production, so specifically testosterone. And this is done by the Leydig cells. So that's a different cell type, and it's going to be outside of the seminiferous tubules. And these are responsible for testosterone production in response to hormone signals from the brain. So in mare physiology, the royal we, I guess, spend a lot of time emphasizing that HPG axis. So the hypothalamus, the pituitary gland, and then the gonads. And that's a really important axis. And that's kind of how all the signals gets transmitted from the brain to the reproductive tract. It's the same idea in the stallions. So we have GnRH from the hypothalamus. I realize you probably can't see any of this in the back, but you have the hypothalamus up here. It's going to act on the pituitary, and the pituitary is going to produce FSH and LH, same hormones we see in the mare, and that's going to act on the testicles to allow spermatogenesis and then also testosterone production. So it's that same axis that we talk about in the mare. GnRH is still at the top of that, and it's going to govern everything that happens below. So these are images and drawings of the seminiferous tubules. As I said, they constitute the vast majority of the testicular parenchyma, and they're basically sperm factories. So this image here is a cross section, the stained one. So that's going to be just a transverse cross section through a tubule. And then the other image is more of a sagittal view illustration, but they're showing the same thing. And again, knowing that you probably can't see anything back there. So this sort of, the outside of this tubule, like the bottom layer, is going to be the basement membrane. And this is where we can actually see the Sertoli cells, those helper cells hanging out. And then all throughout this tubule, we're going to see different stages of sperm cells in the process of development. Outside of this tubule, so in these little triangles that are not tubules, that's where the Leydig cells are going to hang out. That's where testosterone production is happening. Within these tubules, as sperm get closer to their final stage of development, they get closer to the lumen. So the earliest in development are going to be closest to the basement membrane, and then they work their way in as they develop. I think of it as like this kind of spiral of there's always going to be different layers if you take a cross section through, in different stages of development rather. But when they are fully formed and ready to be released, they're released into the lumen of the seminiferous tubule, and that's called spermiation, which is kind of a cute word. And you can see on this illustration, perhaps, we go from these very immature stages of sperm development where they're these little tiny round cells. They get a little bit more complicated, and then you can hopefully make out that these guys actually have tails and more of the normal shape we associate with a sperm. So just to really hammer this point home, sperm production is going to be based on testicular size. Almost 3/4 of that testicular parenchyma is made up of these tubules of these sperm factories. There's something called spermatogenic efficiency, and so that's where we actually figure out how many sperm are produced daily per gram of testicular tissue. And then in terms of sperm storage, so they're constantly being produced. We do have storage in the non-testicular structures. So some of the accessory sex glands, the ampulla specifically, the ductus deferens, and then most of sperm storage is going to hang out in the epididymal tail. And those are the ones that are capable of fertilization. They're ready to go. If you were to collect a stallion daily for on average 5 to 7 days, you can actually get that reserve down to a steady state. So you can get a more similar number of sperm ejaculated every time. So I have alluded to this, I think, a few times, but the sperm pathway. I think it's something important to think about in terms of, I think it helps understand the anatomy, but also just realizing that there's a little bit of a journey from sperm production to ejaculation. So produced in the seminiferous tubules. And so on these images, it's all of these guys that are taking up the bulk of those images. From there, it's going to go into the reedy testes, which is, they're basically little tiny collecting ducts that are going to transition from the seminiferous tubules into the next ductal tubular structure. So they go into the epididymis then, and that's going to be the, so they start out here, they go into the reedy testes, and then we have the epididymal head, the body, and then the tail here at the bottom of the image. From there, this singular tube kind of just changes names and its makeup changes a little bit. But at this point, once we get into the epididymis, it's a single tubular pathway that the sperm are going to take. So from the epididymal tail into the ductus deferens, that will also turn into the ampulla briefly, and then that empties into the urethra for ejaculation. And this is another way of looking at that. So if you follow the red line starting right here in the middle of the testis, it kind of loops around. See this? Kind of loops around, goes up through the epididymis, which is going to run on top of the testis, and then it has to go all the way through the ductus deferens into the ampulla, and then it's going to empty into the urethra, where it travels for ejaculation. This is a little bit of a non sequitur, but I don't know where else to put this in. I just want to mention sperm morphology. So, and that's referring to, we evaluate this by looking at the sperm grossly under the microscope. It's part of a complete semen analysis. There are a lot of morphologic defects that happen during different times of sperm production, and they can have different repercussions for fertility. Some are more problematic than others, some are more common than others, but just kind of a reminder that not all sperm are created equal. These are morphologically normal sperm. So we have a head and a tail. There's no, everything is pretty symmetrical. There's no, serious bends in the tail. We'll look at some abnormalities here. So this is one of the more common abnormalities we'll see are cytoplasmic droplets. This picture is a little bigger, so hopefully easier to see. So we have the sperm head, and then you can see that little bead right underneath it. And that's basically just a blob of cytoplasm. When the sperm transitions from this round little cell into the elongated sperm shape that we expect, there's going to be changes in the cytoplasmic makeup, and that cytoplasm has to go somewhere. So it drops down the neck. First, if you see it initially, it's a proximal. If you see it this close, it's a proximal cytoplasmic droplet. Eventually, it moves a little farther, and it's a distal droplet, and then it will be shed completely. Some of the other abnormalities we can see. So these are in the head, in the acrosome. The acrosome is a little cap that the sperm head wears that allows fertilization to happen. And so with high-powered microscopes, we can actually see we have little craters in these. There's some irregularities in that acrosome, abnormal head shapes. This is another abnormal acrosome. Tail abnormalities as well. These may interfere with, for lack of a better word, the ability of the sperm to swim. So if your tail is not functioning normally, they're going to have a harder time getting where they need to go. But these are extreme situations really of a coil tail. We have this hairpin, like 180-degree turn. We can have bent or broken mid pieces here. This guy has 2 mid pieces, but there are sperm morphology is something we could talk about for a long time, and we're not going to here. But just to be aware that when we talk a little bit about sperm numbers, it's not just numbers, it's quality as well. So just to move on through the process a little bit, I guess, we'll talk about ejaculation, the physiology of this. Because it can be the source of frustration when we have problems with ejaculation. So there's 2 parts of ejaculation. They're both reflexes. That doesn't mean that there's still some brain priming, I guess, that has to happen. And so these reflexes can still be interrupted, or overridden, I guess, would be a better word. So emission, this is a reflex that's initiated by intravaginal thrusts. In most stallions, it's 7 to 9, not 8 somehow. I have 7 to 9 written here though. So that's a reflex. So when the stallion has an erection and begins to thrust in the mare or into the AV, that's going to stimulate the emission reflex. Ejaculation is going to be a different reflex that is the next response. Actually, to back up, so emission is mainly involving smooth muscle. And so this is more of like a passive release of sperm into a lot of those excurrent ducts on their way out. Whereas ejaculation is going to involve skeletal striated muscle, rhythmic contractions, also a reflex, but one that can also be overridden by things like pain or fear or anxiety. But this ejaculation versus emission, this is more the passive kind of release, and then the actual expulsion is ejaculation. So I will mention ejaculatory dysfunction, which is a huge, huge topic. And it's more of a syndrome than a specific condition, which in my mind means there's many different manifestations of it, and we don't really have a good way to address it every single time. So ejaculatory dysfunction can refer to any sort of failure or challenge or interruption in the process of ejaculation. Some of the things that fall under, some of the conditions, I guess, that fall under this blanket topic would be urospermia, so urine contamination. This is a type of ejaculatory dysfunction. It's not terribly common, but it is certainly something we see. And this tends to happen because there's a failure of communication where the neck of the bladder should have the stimulation to basically close itself during ejaculation. So we don't want to end up with urine in our sperm. Now I'm looking at you, Jamie. We have had stallions where last year we had a stallion that kept peeing in his semen, is what they told us. So they ended up giving him a break, collecting a very, very small dose for deep horn insemination later that day. And it was a little bit of a scramble, but it worked. The mare got pregnant. Yes. But urine contamination, it's not super common, but it is definitely a form of ejaculatory dysfunction, that there is something going wrong in that process. The bladder neck's not getting closed shut. Azospermia could also fall under this umbrella term. So this would mean azo meaning absolutely no sperm in the ejaculate. For that to truly be the case in stallions is pretty rare. I have ampullary blockage under here as a cause. So the way I kind of look at this is, so azospermia would be that their emission and ejaculation are occurring, but there's actually no sperm production in the ejaculate. When we have a blocked ampulla, and so if you remember, they're the 2 little like shoelace guys that go over the bladder, and they're connecting the testis to the urethra. So they're essential in the sperm pathway, but they're narrow little guys and they can get blocked in some stallions. When that happens, usually it's unilateral, and we will still see some sperm in the ejaculate. They just might be more dead or more damaged. We don't truly see an azospermia with a typical blocked ampulla, what I think is often referred to as azoospermia is more likely a failure of ejaculation. So we're looking at the non-sperm portion of the ejaculate. We're looking at the seminal fluid and those pre-ejaculatory secretions from the accessory sex glands, but not actual ejaculate. Most of the time, though, ejaculatory failure dysfunction is very frustrating and very kind of vague and nebulous. It can be behavioral, it can be learned. Stallions who have one horrible experience, like you hear stories about the rubber band that was holding the collection bag onto the AV snaps and it hits the stallion and he freaks out and then he will never ever breed again. Behavioral things like that can definitely contribute to this. Pain is certainly a huge contributor to ejaculatory dysfunction. It can be hard to figure out where the pain is, but chronic back pain or any sort of chronic hind limb issues, even hoof abscesses, it's all very stallion dependent how they're going to react to that. But if you do have a stallion that is having a hard time with ejaculation, it's good to rule out musculoskeletal issues as much as you can. Neurologic dysfunction, neurologic issues can also interfere with ejaculation. There are instances where there are ischemic issues in the caudal aorta due to other hind limb issues. And so anything that's going to interfere with blood flow or nerve function sort of in the lumbar area or the hind end of the horse could relate or could cause ejaculatory issues. There are one or two perhaps reports of cysts on a very specific structure that actually prevent ejaculation because they put pressure on the ductus deferens and sperm can't get through. That's not the most common thing. This is a huge, huge thing to kind of work up and try to pick apart. But there are a lot of different factors that can contribute to dysfunction with ejaculation. One other thing I will say, it can be hard to differentiate ejaculatory dysfunction from low libido. Whatever the cause is, though, I have found if you can't make progress and you can't improve the situation, the stallion's usually going to become frustrated and then his libido is going to suffer as a result. And then it becomes this kind of like self-fulfilling prophecy of low libido, difficulty ejaculating, and then it becomes even harder to tease apart what the problem is. Okay, so again, back to sperm production or reflection of testicular size. So we can measure the testicle and calculate the volume of that testicle and then use that volume to calculate what we predict their daily sperm production should be. You can measure testicles with calipers. I find ultrasound to be much more useful, accurate. So you put the ultrasound probe basically on all three sides of the testicle. So we're measuring length, width, height. This image here is the super boring testicular parenchyma on ultrasound. And so if my probe is here, I'm going to measure whether this is width, height, length. Let's say it's width. I'm going to measure from the top here to the bottom of the testis. And then we're going to use those values to calculate the volume of an ellipsoid. And then we're going to use a formula that some very smart people at Texas developed a couple decades ago to actually predict what their theoretical daily sperm output should be. And it's important, I think, to realize this is theoretical. It's what they should be on paper, and that's not going to correlate exactly to what they're producing in real life. But it gives you a good idea of ballpark numbers that you should see based on the size of a stallion's testicles. Especially when you start working with a new stallion, it can help you figure out if he's doing what he's supposed to. Okay. There's a limit to the number of sperm that a stallion produces in a day, no matter how many times you collect him or how many times he ejaculates. So because it's based on the size of the testis and how much they can produce, it's a daily sperm output. It's not going to be an output per collection. That's not how they work. So just something to keep in mind. We're just going to speed through this. We're just about done, actually. But just thinking about sperm numbers, because we've talked a lot about that and how production depends on testicular size. So with natural cover, we have the lowest requirements for sperm number, and that's because the semen is fresh and they're getting a complete ejaculate. The freshness is a big part of that because it means that sperm is going to live that much longer in the mare's reproductive tract. When we're collecting semen, extending it and cooling it to ship it, in general, you want to double the number of sperm you have because there's going to be an expected amount of die-off once you cool and process and ship the semen. Frozen semen I just put on here is a whole different story. We're looking at the fewest sperm possible in most cases, but through really intensive mare management and really careful deposition of the semen close to the oviduct, we can make things work. So I just thought this was a good kind of mental exercise comparing a collection versus a live cover schedule for a thoroughbred stallion versus a standard bred. We're gonna have typical similar lengths of breeding seasons, but most thoroughbreds are going to be breeding 7 days a week. Most busy thoroughbreds are going to breed 7 days a week with more than one cover a day, versus a stallion that's collecting to ship. Usually they'll have an every other day schedule with one collection a day, but that one collection has to get divided into any number of doses. There'll be a limit to how many doses that ejaculate can be split into, but generally you're going to get bigger numbers when you're only splitting that daily ejaculate into 2 or 3 different mares. Again, we have in general, lower sperm number requirement with the live cover versus the ship semen, again, because of that die-off that we expect because of the processing and the time. And with that, I will take any questions. I hope everybody can see this picture. So emission can happen sort of, yes, Miranda, right. The question was, what happens when the sperm that's waiting in the duct, is it just going to hang out in there? What happens with that? So when we start collecting stallions at the beginning of the year or after a long period of sexual rest, we'll often talk about cleaning them out. If they have a rusty load, whatever euphemism you want to use, there's going to be accumulation of dead sperm always. There is some passive release of that always. Like every time they urinate, there's going to be some sperm that's released. They don't get sperm granulomas, like a buildup of dead sperm in stallions the way other species do. But it's always good for that. So there's going to be some just passive sort of getting rid of it constantly. And then this is part of why we do a couple collections before we want to breed a mare to make sure that we have gotten rid of that buildup of dead sperm from the off season or a long period of sexual rest. So the question was about an older stallion that it sounds like is bellying up before he's in the mare.
Yeah.
And so I think that's and he's breeding mares live cover.
Yeah.
For that, I would think it would be more of, so ideally you want the stallion, you need to figure out the timing between when he gets an erection and when he actually thrusts into the mare.
So my name is Allie Catalino. I'm with the Equine Clinic at Oakencroft, and today I'm going to talk about some alternative therapies for your breeding stock. Most specifically, we're going to talk about chiropractic and acupuncture. A little bit about me. I graduated in 2018 and began chiropractic about 1.5 years ago, and acupuncture I just finished with my certification on. So I think it's really important to look at an integrative approach sometimes when you have patients that aren't necessarily reading the textbook. Thank you, Miranda. Sorry, people in the back, you can't hear me just wave around. Some patients don't read the textbook for us. You know, we can do X, Y, and Z and medicate them appropriately, and yet still we don't get the outcomes that we were hoping for. So that is really what made me look into studying chiropractic and acupuncture to help those patients a little bit farther along, maybe that last 15 or 20% to get them functioning how we would like. But it's truly an integrative approach. So I just want to stress that we still assess the patient from a Western medical standpoint. We discuss the presenting complaint with you guys, which for the purposes of today would be some sort of reproductive problem, whether it's a low libido or we can't get a mare pregnant, go over relevant history and physical exam, do any blood work that we need to do and additional diagnostics, and then proceed with whatever medication we would normally choose before deciding, is this animal a good candidate for chiropractic care, acupuncture therapy, some herbal medication to tack on, and when would be an appropriate time to do a follow-up. So just the nuts and bolts of what chiropractic is, and I'll go through acupuncture as well. I'm sure a lot of you have seen this before or have had it yourself. We do a whole separate examination that is based on basically looking at the musculoskeletal makeup of the horse. We're going to look at them standing still first. Do they have any muscle asymmetries? Are they resting one leg over another? Are they shifting weight? Then we're going to watch them in motion, again, looking for symmetries, asymmetries in motion. Do their hips move differently? Does one leg reach forward differently, or is it being left behind? And then we're going to move into palpation, again, feeling for the muscles, feeling for abnormal motion in the bones. And one final swoop is the spinal temperature, and tell us if there's any heat in one specific area or if they're cool. It can all clue us into where the problem might be. And then we go ahead, get on our chiropractic bales or a ladder or whatever we're using and diagnose a stuckage, which the real term for that is a subluxation. So that's an area where there are two bones that articulate and they're not moving appropriately. And then we apply a high velocity, low amplitude thrust to that area to break up the stuckage. This is very layman's terms for what we're actually doing, but I'm going to describe this in a moment. And the whole idea is that we want to restore normal range of motion. And when we restore normal range of motion, we are reducing inflammation, potentially reducing pain, and increasing their regular function. So I have down at the bottom some fun images. The skeleton of the horse, they have 7 cervical vertebrae, 18 thoracic, and 6 lumbar, which means there are multiple joint spaces between each and every one of those bones. And then, of course, they have joints through all of their limbs, which we can work on and make sure that their mobility is moving appropriately there as well with the same technique. This graph, you don't need to see the words, that's okay. I'm glad that it's bright colors because it shows us the normal range of motion of a joint. So the normal range of motion goes from the full 90 degrees. And essentially the light blue and yellow is what happens when we'll use your finger, for example. So I'm going to move my finger back, and as far back as I can move it, that's what the body can do on its own. And then there's another passive range of motion where I can move that just a little bit farther without experiencing any pain or discomfort. And then beyond that is where you start causing injury. So we don't cause injury until we get beyond that green line at the bottom, which is the anatomical barrier, which is the normal range of motion. In chiropractic care, we don't even approach that. We stay above and within the normal range of motion. We don't want to cause any sort of injury with these guys. This is a really cool picture just to show, again, all of the articulations that happen within the pelvis here. So right up here are the wings of the pelvis. And then you can see we're looking kind of front to back, inside the horse, only bones, everything else removed. Right here, the intertransverse joint, the disc joint, the facet, those are all separate joints that can be affected when the horse has inflammation or a lack of motion. And I picked this picture to show you guys because the horse is in rear wheel drive. It's a rear wheel drive vehicle. Everything starts from behind and has to move up and translate forward. So right here in the pelvis, sacrum to lumbar area is where we need to translate energy. And so there's a lot of motion there, and that leaves a lot of room for things to not function appropriately, which causes pain. And a little fun fact that I like to share is that this intertransverse joint is only in horses and rhinos. Fun fact for the day. So chiropractic care, you know, I showed you that diagram on where the physiological space is within a moving joint. We don't ever go beyond those structures. So a chiropractic adjustment should be quite comfortable. The patient should enjoy it. They might feel a little bit of discomfort. There's a reason that we're there. So a little bit of discomfort and on edge when we first put our hands on them, but then once they realize that what we're doing actually feels good, raise your hand if you've gotten adjusted before. A lot of you. Yeah, it's a little bit alarming when humans get adjusted, right? Because there's all that snap, crackle, rock, whatever, what all those words are, all the way up your back. Horses do not have those audibles typically, so a little bit less disconcerting to them when we start adjusting. But they do, you know, when you get there, you get in that precarious position at first, it's a little bit nerve-wracking. Then it feels really good. So usually our patients look like these guys. What proper chiropractic is not, this is a castration, but it's just to show you that proper chiropractic is not performed under sedation or general anesthesia. We want their muscles to help us. We don't want their muscles disengaged. So if you see somebody adjusting a horse under anesthesia, walk away. Proper chiropractic does not require mallets. It does not require blocks. It is just your hands. And again, I just want to stress, these horses really they usually enjoy their chiropractic work. So for reproductive purposes, case selection for chiropractic care, stallions, they often are collected pretty frequently during the breeding season, especially the thoroughbreds, as Dr. Pash was just telling us. They can get pretty uncomfortable. It's a really physical job and they're not necessarily doing it all winter. And then we're asking a whole lot of them. So they can get uncomfortable, which can lead to low libido, among other causes of low libido. They also can be injured as they get older and their tendons and ligaments aren't necessarily ready to jump right back into a breeding season. We also may introduce chiropractic care as a preventive therapy for the same reasons listed above. Mares, if they've had a difficult foaling, it's a great time to come through and do a gentle, because I'm sure they're sore, a gentle but thorough adjustment and make sure that everything is moving appropriately, because they've got a lot of other things that they've got to focus on. Musculoskeletal discomfort. And again, we can put preventive therapy across the board for these guys just to keep them moving well. For foals, of course, we're going to be extra careful. Very gentle, small adjustments and only a couple usually for them. But if they were through a difficult delivery and are having a hard time ambulating, we can assess them if they have a traumatic injury, which I'll go over a case of traumatic injury in a youngin in a few minutes. Or if they're a dummy foal, again, just to get their nervous system functioning appropriately. Acupuncture is probably something that people have a little bit less experience with. Raise your hand if you've ever seen or had acupuncture. Okay, good. Lots of people. Good. So I'm going to ask you to kind of set your Western medical mind over here and get a little colorful with me as I tell you kind of how acupuncture works. So traditional Chinese veterinary medicine actually includes acupuncture, herbal medicine, Tuina, which is a type of soft tissue manipulation, and as well food therapy. It's 3,000 years old or more, and it is used to work on the animal or the human's energy systems that they've already got to maintain their own health. And we have focused on, again, this is a small image, but these lines are called meridians, and they are to demonstrate the flow of energy in a normal patient. And when we are dealing with any sort of discrepancy, whether it's musculoskeletal or they're having a health issue or they're a dummy foal, the energy isn't moving appropriately. Again, we can use the word stuckage, but it's very different here. And then we focus on acupuncture points, which are powerful points along those meridians, which help us to move the energy back where it's supposed to be going. Just a little bit bigger of an image for you. And as you can see here, we don't have them all labeled on this image, but there's about 400 acupuncture points Many of them are derived from humans, but we also have some that are specific to each species. The TCVM exam is quite different from what you might see in the Western world. We're going to start by looking at the tongue color, and not so that we know if they're perfusing their tissue well, but so that we know if they are dealing with a deficiency or an excess. We assess the shape, the color, the texture, the coating, just from a little peek in the side. We also look at their pulse quality. For this exam, we do a pulse diagnosis at the base of their neck. We feel how deep, how strong, how potentially weak the pulse is on one side or another. If the pulse is weak on one finger, but not a different finger, that can tell us a whole lot. So again, totally different. Then we look at constitution, which is pretty cool, which is essentially like figuring out the personality type of the patient that you're working with. And we file them into wood, fire, earth, metal, and water. We'll go through those a little bit so you guys can kind of think about your horses at home and decide what constitution they are. I love doing that with mine. And then we go through and do an acupoint scan. We scan right over the points and see if they're sore in any, and choose some strategic points to help treat the patient. Okay, so this is the fun part, constitutions. Think about your horses, dogs, yourself, your friends while we go over this. So the wood constitution is associated with the liver organ in TCVM. These guys tend to be competitive, confident. They're assertive, strong, athletic, and you can really make them angry. This is my Jack Russell. He's a wood. When these guys are unbalanced, you might see tendon or ligament problems. You might also run into liver disease. They could have red eyes or become excessively irritable or have hoof or nail problems. Fire constitution. This is associated with the heart organ for TCVM. These guys are playful, friendly, affectionate. They just want to be the center of attention. They are through and through your golden retrievers. And I'm sorry, I know this is a room full of horse people, but I feel like dogs are just really easy to kind of file under these different constitutions. So you understand what they are. When these guys are unbalanced, they have behavioral problems, anxiety, they can be spooky, mental disturbances, or heart issues. Earth, associated with spleen. These guys are your fat, lazy labs that want to eat all your butter. When they're balanced, they're relaxed, they tend to get a little chunky, they like to eat, and they're very loyal. When they're unbalanced, you might see anything that has to do with the GI tract, loss of appetite, diarrhea, colic, muscle atrophy because they're not getting the proteins that they need, obesity. Metal constitution is associated with lung. I tend to be a little bit more metally. These guys are order and rules, and I'm sorry, is that in the spreadsheet? No, can you add it to the spreadsheet? They're those types of people. They're your border collies. When they're unbalanced, you might see nasal discharge, anything in the sinuses or lungs, and a dry hair coat. Lastly, we've got our scaredy cats, the water or kidney group. These are your Italian greyhounds. We don't see very many horses that are primary water constitution because they wouldn't have survived this long. They're scared, timid, shy. You know, the crew's going this way and they're over here shaking in the corner. When they're unbalanced, though, they might have a lot of issues because in the TCVM world, kidney is really important. It is the source of energy for them. And we're talking Chinese energy. So it's the source of their energy at the beginning of their life. It can be the main thing that we need to target when there are reproductive problems. And then I threw this image up there just so that you can see we've got each circle is a constitution. You don't need to see the tiny little minutia, but they're all interconnected in multiple different ways. So if you have a wood patient that doesn't necessarily have a liver problem, there are a lot of different layers to this Chinese medical onion, and it probably does make sense. It's just a little bit deeper. I threw some pictures of acupuncture on there, but in the interest of time, I'm going to fly through them. After we apply the needles, we then attach electrodes, and if the patient allows, we'll run electricity down the meridians to help, again, increase the energy flow if it's necessary and help with the problem at hand. Sometimes when you are working on a horse that really needs their acupuncture and really has a stuckage or an increase in energy flow, this happens. So if you can't see this in the back, these are all my needles out of one horse, and they all came out bent, like at least 45 degrees or more. This was the first day we treated her, and each time we treated her, moving forward from there, the needles were less and less bent, and now they come out straight. So some of you might be thinking, if your horse doesn't like needles, are they a good candidate for acupuncture or Chinese medicine? And there are still a lot of ways that we can manipulate their energy and work on the acupoints without using needles. The top left, it looks like a cigar, but it's called moxibustion. Moxa is a stick of herbs that burns really slowly and really hot, and we can use it in close approximation with the acupuncture points to stimulate but not burn the patient. It just warms them up. It's nice for winter treatments as well. And then we can also do laser on acupoints, shockwave. The bottom left is Tuina, which is again just a soft tissue manipulation over the acupoints, and the additional herbal therapies helps these guys quite a bit. I see I'm somehow already at 12:13, so we'll do this part really quickly. Case selection for acupuncture, pretty much above all of these, you can use acupuncture for anything. It's another type of medicine entirely, but the disclaimer, Western medicine is there for a reason. So if we have a problem with a mare, a foal, or a stallion, we need to make sure that we're dotting our I's and crossing our T's first with whatever diagnostics are recommended by your regular veterinarian and the appropriate treatments. And then maybe we can do an integrative approach and add some herbs or some acupuncture on top. Acupuncture is reportedly very helpful for reproductive problems. I've listed a few here. Stallions, cryptorchidism, low fertility, low libido, pain management for mares and foals as well. They really help with mares that you can't get to cycle, and ovulatory follicles despite being on lights. Some of those older mares that aren't clearing their fluid, throw acupuncture at them and see if that will help too. And I just want to say one really quick case before I have to get off here. We were just working, myself, Dr. Goslin, and Alana down at Millbrook, we're working on this 3-year-old stallion who was a bilateral cryptorchid. His testes were up in the inguinal ring. Essentially, we threw HCG and acupuncture at him, and after 5 treatments, he has 1.5 testicles. So we're working on the other 2, and hopefully he will be a good candidate for breeding.
Well, good afternoon, everybody. I got the lucky slot of being right after lunch, so hopefully if you take a nap, I won't call you out, I promise. Just get rested up for Dr. Timon coming up after me. So my name is Brian Craig. I work for Merck Animal Health. So came to you from Oklahoma yesterday, and glad to be up here. And I'm in the same exact weather, so we have the same fog and nasty winter in Oklahoma right now as well. I'm going to talk to you a little bit about vaccination in your herds, kind of the whys, and then some considerations. I'm not going to get too deep into details. If you got questions on specific protocols or vaccines, I'm happy to answer your questions after, but this will be kind of a high view of vaccination programs. And just a little bit about my background. I, in a previous life before this job, ran a breeding farm in Oklahoma that we would breed between 1,000 and 1,200 mares a year. So I've been in your shoes and guarantee you I know all your situations pretty well. So if you got any questions, happy to talk through them. So kind of want to just start off of why do we vaccinate? So vaccines are going to be the easiest and most economical way to protect your herd. You know, natural immunity is great, but if we can give them a bump up through a vaccine, that's going to be a lot better process for us and the horses. We all know illness can be a big toll on especially an athlete in their life. You know, we may miss a full show season, a full race meet, you know, a full summer if we're using that horse for pleasure. So properly vaccinated horses are going to have a better time through that. And then we just get improved welfare for the horse. So they're not having to suffer through illness like a horse that's naive or has gotten to a point in life where they're not able to fight disease as well, and they're undergoing those illnesses. So some things to think about. Vaccination does not equal immunization. So just because we go and we give a shot, that doesn't mean all of a sudden that horse is immediately protected or 100% protected. So after vaccination, so after we've given that dose of vaccine, we have to rely on their immune system to produce antibodies or cell-mediated immunities. So we have to teach that immune system to fight those particular diseases. And that's what we're doing when we administer those vaccines. Most horses are going to have a nice, clean response to vaccination, but not 100%. So just be aware that there are going to be those outliers out there that may not respond quite as robustly. Some horses respond more robustly, and we'll kind of get into that a little bit later. So not all of them are going to be the same, and we need to keep that in mind as well. Next thing, vaccination is an aid in the protection of disease. So it's a part of the puzzle, and I'll kind of touch on that as we go through this talk as well. But just need to keep in mind that no matter how great your vaccine program is, we don't have good management around it, then those vaccines aren't going to succeed like we would like them to. So getting into the kind of the topic of the day, when we talk about pregnant mares and vaccines, and I'm going to kind of start at the pre-foaling part of their life, and we'll sort of stepwise move through it. But we want to vaccinate that mare 4 to 6 weeks prior to foaling. And I've got it up here on the slide. I meant to have this hidden so I could ask you the question. But the reason we're going to do that is so we can spike that colostrum. So we get the highest level of antibodies we can in the colostrum. So when that foal nurses, they're going to get the best passive, what we call passive immunity from that mare. So when a foal's born, they're basically born with no immunity. And then it's passed from the mare through that colostrum into the foal. So that's where we get the term passive immunity. But vaccinating the mare alone isn't going to be sufficient. So she may have great levels in her colostrum, but if that foal doesn't nurse in a timely manner or doesn't absorb like we would hope, then they may not have adequate protection. So we want that first meal, ideally within a couple of hours. If they haven't nursed within 8 to 10 hours, then I'm going to start getting fairly concerned and think about intervening. But we for sure need it to happen before 24 hours. So once we get to 24 hours, that foal's gut has closed and they can't absorb those antibodies anymore. So if they nurse for the first time at 30 hours, then they're basically left with no antibodies in their system. So we really need to get that done as soon as possible. So if that foal hadn't nursed pretty quickly after birth, get a hold of the clinic. And, there's lots of things they can do to help via nasogastric tube with colostrum or plasma or something like that. So colostral antibodies are going to provide protection for several months. So that what they get from the mare is actually going to protect them for up to about 6 months, which is great. Except we have to consider that when we get into our vaccine program. So if we vaccinate a foal too early, those maternal antibodies can interfere with that vaccination process. And so it'll kind of neutralize that vaccine. It's not going to hurt the foal, but if we do vaccinate too early, we may have to vaccinate more times to get that foal's immunity to the level we want it to be. And how many of you are utilizing plasma therapy on your foals out there? So I see quite a few hands up. So plasma is another adjunct. So we try to use it always if we have a failure passage transfer. So if they didn't get enough colostrum at birth, but a lot of farms with high pressure from disease will use it across the board just as an added layer of protection. So they get a very high level of plasma antibodies from that, but those can interfere as well. So We want to be cognizant of that when we're designing our vaccine programs and not start those vaccinations too early. Like I said, if we do, then we may have to add an extra dose in there just because that first set of vaccines may not take as good of effect as we want. So for most killed vaccines, when we're talking about our foals, we're going to look at 3 doses for primary immunization. So the first dose between 4 and 6 months generally, so kind of around that weaning time. A second dose 4 to 6 weeks later, and then a third dose around 10 to 12 months of age. So for that first dose, I prefer, if I can, and I get all management's different, and sometimes it's not possible, but if I can get that first dose in the foal a couple of weeks prior to weaning would be my preference. Anything that causes stress in that foal is going to decrease their immune response. So if we're weaning and vaccinating at the same time, we're not going to get nearly as good a response as if we give that vaccine a couple of weeks prior to that weaning event or a couple of weeks post once they've settled in to their new life and, you know, aren't quite as stressed. But if ideally, I'd like to do it while they're still in the mare a couple of weeks at least prior to that weaning event. So I've got this graph up here just to kind of show why we do those 3 doses. So if you look at that, can everybody see that, those spikes there on the pink line? So we look at, that would be the immune response we get, the first kind of hump there, the immune response we get after the first dose. So we're going to get a response, but I wouldn't call it necessarily all that protective. And then when we come back 4 to 6 weeks later and give that second dose, then that immune system recognizes that antigen or that disease we're trying to protect against, and we get a lot more robust immune response. So they're a lot better prepared to fight that disease after that second dose. And then we come back at that 10 to 12 months of age on the third dose, then that immune system is kind of moved on to, let's say, college age in their education against that disease, and we get a kind of the peak immune response. So that's why it's very important to give that first, second, and then follow up with that third dose so the immune system learns as best it can and can fight that disease to the best of its ability. I just got a few slides here to make the point of why we need that added management practices or biosecurity. When we look at natural immunity in a kind of normal disease challenge, we have a gap there, hopefully, in a normal horse. If we look at a vaccinated horse compared to a well-managed farm, you can see we really increase the gap between that disease challenge and the immunity. So we're going to see a lot less sickness in those horses if we've got properly immunized animals along with good management practices. But when we slip up and we don't practice biosecurity, you know, our management's kind of slipped. Maybe we got too many horses on one place. We got horses coming in and out, and we're not doing a good job of keeping things quarantined. And maybe we are kind of lax in our vaccination protocols. That's when the disease challenge is going to overcome the immunity, and that's where you end up with disease outbreaks on the farm. So one thing that sort of want to lightly touch on, I don't want to make too big a deal out of it, but vaccine-associated adverse events will occur. I mean, we are priming the immune system, so while they are pretty rare, our vaccine line that we produce at Merck is about 99% reaction-free, but we do see some things occur after vaccination. And a few of them I want to touch on that I would consider within normal range. We can see just a small local swelling sometimes at that injection site, lethargy, so especially in the foals, they'll be a little dumpy for a day or two. Maybe a little bit of soreness at that injection site, and then sometimes a low-grade fever. So those things I would consider completely normal within the realm of immunization. You know, if it's only a day or two after vaccination, I'd certainly keep a close eye on them, but I wouldn't get all that concerned. If they persist, then it'd be time to call the clinic back out. The the things that I do get worried about, and I do want to make an immediate phone call back to the clinic if they've already left the farm after vaccination, is if we see hives. So if we've got bumps around the neck and thorax, colic, any kind of infection or abscess. So if that swelling gets pronounced, or we see drainage or something like that. And then of course, anaphylaxis would be worst case scenario. That if you haven't seen it before, you'll know it if it happens. It's almost immediate. So the veterinarian would more than likely still be present when this happens, but it's an extremely rare event. We don't see that very often. But just kind of want to make the point of those four at the top, that you're going to see those from time to time, and they're a fairly normal response to a horse receiving a vaccination, and that's basically their immune system at work when those occur. So if you've got questions on guidelines, if you want some help developing in a vaccine protocol, in addition to talking with the veterinarians at the clinic, the AAEP, or American Association of Equine Practitioners, they put out a great resource that's available to the public. It comes in this table form, and we'll kind of walk you through the different stages of life, the different diseases, and when they should be vaccinated, or if they should be vaccinated for those particular diseases. They have one specific for adult horses and one specific for foals. So has anybody utilized that before or know about that? So I see a few hands out there. So that's a great thing to kind of educate yourself with before you talk to the clinic and try to develop or tweak your vaccine protocol. So it just kind of gives you a great set of guidelines. So then the next thing I wanted to touch on with your brood mares is EHV1. So I think we all probably know about rhino or EHV1 herpes virus. Gets a lot of press out there at the horse shows for neurologic disease, but our main concern in the broodmare realm is going to be late-term abortions. Sorry about that after lunch. I didn't know my slot, so I probably should have chosen a different picture. So we don't really see any warning signs with this. The mare will appear healthy. It's usually going to be in the last trimester, and we'll see a near-term foal aborted. And the foals generally look pretty normal as well. So to reduce that exposure, we want to keep mares separated from horses traveling up and down the road if we can, young horses, and just kind of try to keep the brood mares to themselves and away from the rest of the animals. Herpes virus is something that about 85% of horses get within the first 10 to 14 days of life. And then they harbor it in their body, and it does what we call recrudesce. So it pops back up at times of stress. And so when it does that, it can create a situation like this with late-term abortions. So when we look at brood mares, pregnancy has an immunosuppressive effect. So especially in that last trimester, and this is part of the reason that's why we see the abortions during that third trimester, is their immune system actually becomes suppressed because of pregnancy. If they didn't, they'd have more problems with their pregnancy. So they have an increased susceptibility to EHV1 during this period. And that's why we have kind of a different vaccine schedule for them when it comes to rhino. So we have a vaccine called Prodigy that's specifically labeled for protection against abortion. We're going to use that during 5, 7, and 9 months of pregnancy. So that's a lot more frequent than we're given the other vaccines in a horse's schedule. But because of that immunosuppressive effect of pregnancy, it requires repeated vaccination for that broodmare for protection. The other thing we want to do, as I said, practice good herd immunity. So if you can't separate your broodmares, if you've got geldings or young horses that are housed around those broodmares, it's a decent idea to keep them on that same vaccination schedule. So not only does this vaccine protect against the disease, it also reduces viral shedding. So that horse that's been vaccinated, if they do have that recrudescence, or if they are affected with EHV, they're not going to shed nearly as much virus from their nasal secretion, so they're not nearly as infective to the rest of the herd. Again, biosecurity, got to throw that one in there for you. Minimize stress as best we can. So late-term mares, I don't like to haul, halfway across the country if I can avoid it. I don't like changing their population, so taking them out of one pasture and putting them in another, or even moving them across the farm or changing schedules or anything like that. The more we can keep things the same for them, the less stress they're going to encounter, the less chance they have of herpes virus being a problem. I think I've already covered the rest of those bullets there. So just kind of to wrap up on actual vaccination, this is just an example for a foal. If I was managing a herd at 4 to 6 months, I'm going to give him our vaccine called Prestige 5, which has got Eastern, Western tetanus, flu, and rhino. Along with the West Nile virus and an Equirab, so a rabies vaccine. Come back 4 to 6 weeks later with that same protocol. And then at 10 to 12 months, I can either do that same protocol minus the rabies, and I'll tell you why in just a second. Or at that point, I may add a modified live flu along with the herpes virus vaccine for them. Just that modified live flu gives a kind of a different spectrum of protection against flu. And so we get a more comprehensive immune response in that animal than we would if we just used the killed vaccine the whole time. And so on the Equirab, the reason that we're only going to give a dose at 4 to 6 months and 5 to 7 months and not follow up at 10 to 12 is rabies is very immunogenic. So if a foal's born to an unvaccinated mare, they actually only need 1 dose of rabies. We give 2 doses from a vaccinated mare because of that colostral interference, but they only need 1 dose once a year for the rabies, and they remain well protected. So we don't need to come back and give a 3rd dose of rabies at 10 to 12 months. To kind of to wrap up on vaccines, what role do they play? Again, they're going to reduce viral shedding, which is huge in biosecurity and herd immunity. So the better the herd is vaccinated, the less an outbreak is going to spread, and the less chance we have of getting out of control. And then I have decreased clinical disease. So while our goal is to completely prevent clinical disease, every once in a while we are going to see a horse that's vaccinated maybe get, 1 to 2 days of illness, where an unvaccinated horse might get 5 to 7 days of illness. So decrease in disease is our goal there. And I will mention with our vaccine line, we do have a guarantee. So if the vets from the clinic come out and vaccinate your horses and they come down with one of the diseases listed on that vaccine, we will pay for diagnostics and treatment for that particular disease complex. So just kind of a visualization here of what can happen if we do get a sick horse on the place. Kind of think of the cascading effect there. If you've got, let's say 1 yearling in the barn that comes down with flu, they can affect everybody within about a 50-yard circle of them. So if you've got 1 foal that gets the flu, pretty soon you're going to have 3, and that just cascades and can spread to the whole farm pretty quick. Unless you can have 50 yards between every set of animals, it gets tough to control. And I haven't seen very many places that has that level of biosecurity. So, and just kind of wrap it up. Again, I know I've repeated myself several times, but that was on purpose. That vaccination plus biosecurity is going to be the best bet. So vaccination is going to go a long ways in teaching that immune system to fight disease. But if we don't practice really good management along with it, that disease can at times overcome our vaccination protocol. So we need to kind of marry those 2 up and make sure we stay on top of both of them. So the question was, given the vaccines individually versus in combination, I'm not sure that was me. It might have been, but so our combination vaccine that I mentioned that has 6 different antigens in it was actually, that's how that was tested. We did challenge studies with that big combination vaccine, and those horses remain protected against those diseases in combination. The thing that generally causes a reaction with the vaccine is the adjuvant. So that's what makes up most of the liquid in a vaccine. So actually, by giving it a big combination, we reduce the amount of adjuvant that they're given. So it should, in theory, reduce the reactions you would see, but we still get a very robust immune response.
Okay. Thank you all for joining us. Thank you, Dr. Craig, for that presentation. I'm going to be talking about angular limb deformities today. My name is Jessie Tima, and I am one of the surgeons at Rhinebeck Equine. When we think about the timeline of musculoskeletal surgery in the growing equine athlete, this shows us going from foal up to our athletic years and some of the athletic injuries that we sustain. Today, we're going to hone in on foals with angular limb deformity, is looking at our foals from neonatal up to 30 days, up to the weanling, up to the yearling stage. So focusing in that range. Just an overview of what we'll go through today. We'll talk about some terminology, etiology of angular limb disease, and what that means is why does this happen? The importance of angular limbs and why we need to manage them really carefully, how we make that diagnosis, and recommendations for treatment. So we're going to start off really basic here. I know we have a variety of people of different backgrounds and different experience levels here. So just to start off, basic terminology that may be interchangeable during this presentation. The corpus is also known as the knee at times. The fetlock can be referred to as the ankle. The tarsus can be referred to as the hock. And these are three joints that we're going to think about a lot when we're talking about angular limb deformities in general. Looking at, this is an x-ray of a fetlock or an ankle, and on two areas of interest here. This is the actual joint level itself. So this is where the cannon bone is going to meet the long pastern bone, and then the growth plate, which is the official term for is the physis, that we're focusing on is going to sit here above that joint level. So you can see that this is a projection from front to back. This is a projection from the side of that joint. Some more directional terminology here. Anytime that we talk about anything proximal, that means up the limb. Distal is down the limb. Lateral is on the outside of the leg. Medial is on the inside of the leg. Dorsal is on the front of the leg, and palmar is on the back of the leg. If we're talking about a hind limb, we call it plantar, though. Getting into the deformities themselves, we have two main categories. We have angular deformities, which occur in the frontal plane. So from side to side, when you're looking at from the front or the back of the horse. And this is really where our talk is going to focus on today. The other type are flexural limb deformities, which happen in the sagittal plane. So we're talking about from front to back, either contracture or laxity. Focusing on those angular limb deformities, there are two main categories. We have valgus and we have varus. Valgus, with an L here, is when from the point of the joint that you're talking about, the limb deviates lateral from that point. And varus is where from the point that we're talking about, which is going to be right here, the limb is going to deviate medially. It's going to be a little bit confusing sometimes. So an easy way to remember this is to focus on the L in valgus and to think that that L means the limb moves lateral below that level. Just a quick point that I want to make is a little bit of a sidestep. We talk about bench knees, doesn't quite fit any of these. Offset knees. These are when we have knees or carpi that are offset from the limb below. These are actually a combination of a valgus and a varus deformity. And these guys also sometimes have fetlock issues as well, where they have fetlock varus that can be difficult to manage. This doesn't really fit strictly into that valgus or the varus deformities categories themselves, but it's important to mention. When we talk about etiology, we have two main categories as well. We have developmental or congenital, and we have acquired. Anytime that I think about anything congenital, I just hear Lady Gaga singing Born This Way. So I put that up here. But really, we're talking about nature versus nurture. Did the foal come out like this and have issues that led it to have deformities in its limbs? Or did they develop because of the way that the foal grew or the environment that the foal was in? This is I'm sure you guys probably cannot see this chart, but this is a chart that goes through those different reasons here, talking about the perinatal factors. So these are the born this way factors versus the factors that affected the foal after it was on the ground. We're going to go through a lot of those causes. So from the congenital causes, we are looking at incomplete ossification of our knees or our hocks, or our carpi and our tarsi here. This often occurs in foals that are born premature or born dismature. So these foals are coming out, and oftentimes they can have other problems than just musculoskeletal problems as well. But focusing in on here, with incomplete ossification at this level, the way that the foals are loading their joints, they're going to create imbalances if we're not restricting them and supporting them properly. Young foals can also have a lot of periarticular laxity. And what that means is that the soft tissue structures that are around the joints aren't adequately supporting the joints for them to bear weight evenly through that joint itself coming out. Typically, in the average foal, if we have some mild to moderate periarticular laxity, we see this improve within about 30 days of life as those soft tissues become less elastic in nature. I'm going to move on to talk about the acquired causes, there's a much bigger list for these. So some of those include exercise, nutritional imbalances, a heavier body weight, trauma, whether that is a single overt traumatic event or small cumulative trauma to the growth plate or joints over time, and then any type of contralateral limb lameness as well. Something that's important to note, I think a lot of our acquired angular limb deformities are going to have to do with fasciitis. And what fasciitis is just inflammation of that growth plate level. So this is a histology slide. So looking at the cellular level to see this is the actual growth plate and this is heading up towards the joint here. So these are the cells at this level, and looking at this proliferative zone of cells where we're going to have replication of cells in a process called endochondral ossification, in which cartilage becomes bone and the long bone is going to grow longitudinally from this level. When we have microtrauma of this level, or really any trauma, so one major trauma to the physis, say a fracture that occurs across the physis, or microtrauma where that foal is just loading perhaps one side more than the other repeatedly over time, it's going to cause inflammation, and the physis is going to want to shut down when that happens. It's important that we notice this early. With that inflammation, we'll often have a change in just our physical exam where we will see bumps on the inside, typically on the inside on ankles, on limbs because of the way that they're loading them. This type of fasciitis from this reason happens more commonly on the inside of legs because they're naturally loading the insides more. These can become severely inflamed and really cause significant angular limb deformities if they're not caught early. So it's something that's important to keep an eye on. This is an example of x-rays of fasciitis. So what we're seeing here, these are front ankles of the same foal just next to one another. And you can see that the way that the bone is shaped in these corners, it's more proliferative than the outside. There's more white, which is sclerosis. And there's more irregularity at the margin of this, and it's becoming pointy. And as this happens, there's less longitudinal bone growth happening on this side and on this side. And as normal growth is happening on the outside, these ankles are going to start to turn in subsequently. See that there? I think the incidence of disease, angular limb deformities in general, it's really hard to quantify because how it is defined, I think, is pretty subjective. And finding a controlled population on which to measure this is pretty challenging to be able to observe it as continually as it needed to be because it is such a dynamic process. However, there is one group out of New Zealand that looked at a group of a really large population of standard red foals in a year, and they found that incidence to be about 15% of their breeding population that year. And that's really, the data is quite limited otherwise, but to give you an idea of approximately how many foals are going to have angular limbs that are truly going to need to be managed. I think it's important to ask why do we care? Why is it important to talk about angular limb disease? Why is it important to talk about the management? And for me, there are really three reasons to consider. First off, we want these horses to have good conformation when they're going to sales, ideal conformation for buyers. We want any manipulations that have been done to have a good cosmetic outcome in this setting. Next, we want to have a protective athletic conformation for when these horses are athletes. When we think about example here being our thoroughbred racehorse, looking at these injuries that some of which are severe and potentially career ending or transitioning to second career, we're talking about injuries that are all at the level of the fetlock here and the carpus. So these are joints that are under a lot of stress when these animals are doing an athletic job such as this. So it's important that we're setting them up for success by having the most sound joints that we can when they are young. Lastly, thinking ahead to their future joint and musculoskeletal health, perhaps they're beyond their initial racing career. These are some pretty extreme examples up here for those of you who can see them. But we are looking at animals that are going to need lifelong corrective farriery, that are probably going to be unsound for athletic job, potentially even for pasture. Animals are going to have crippling osteoarthritis, animals that are going to be loading their limb abnormally. We can see some splint exostoses here. So pretty severe compensation can happen due to this if it's not managed appropriately early. Looking at these animals compared to our foals, we want to intervene when they're foals. They're only a couple hundred pounds at this point. You're thinking about 1,200, 1,400 pound animals and how much load is being sustained by these limbs that are severely abnormal. It's a lot more stress at that point too. So moving on to the assessment and diagnosis, there are 4 pieces that we're going to go through here: static evaluation, the evaluation of the hoof, the dynamic evaluation, and diagnostic imaging. So I think first it's important to talk about what is normal. When we think about our neonate and our young foal, they are born with an extremely narrow chest, long legs, and a short neck. For them to be able to reach the ground, for them to be able to move around, they need to be base wide. Naturally, by being base wide, they're going to have a rotation, an external rotation out, and they're going to have a mild carpal valgus. You can see that this is shown pretty well here. And what's important about this still image as well is that we are in line with the front of that cannon bone. So we're not standing directly in front of the foal, but we're recognizing that this foal naturally has an external rotation of the limb, and we're standing there to judge the rest of it. And we can see that mild carpal valgus that is permissible in this age foal. As that foal grows up, those valgus, those mild valgus deformities are going to autocorrect as that foal gains a chest and its limbs are going to come in more. So again, talking about the static evaluation, it's important that we're pulling these foals out of the stall and putting them on even ground to do this. And what we can see here is these footprints indicating the observer are looking directly in line, perpendicular to the cannon bone or the carpus is what we say. Not standing directly in front of the foal, and allowing the foal to evaluating them at a few different places in time too, because how a foal stands in any one given space may not be how it always is. So I think it's looking at the repeatability of that. So stand it up, let it walk a few steps, stand it up, let it walk a few steps, see how the foot lands, and then line yourself up in that space and see what you're looking at over several instances. One really good way to do this is by using an imaginary dot system on the leg. So you can see that where these dots are placed, we're looking above the carpus, at the carpus, and below the carpus, above the fetlock, below the fetlock, the coronary band, and in the middle of the foot. If you draw a line here and you are able to connect those lines, it's going to be easy to tell whether you're working with an angular limb deformity or rotational limb deformity. If the lines line up, you're working with a rotational limb deformity, even if you're looking at the foal and the leg seams out. If you have a bend in the line, you likely have an angular limb deformity. So that's something that can be helpful as well when you're looking at, say you're getting pictures sent to you and you have to evaluate those pictures without actually getting to interact with the foal or move the foal and have it and look at it yourself. That's something that can be helpful in that realm as well. This is a really good example of where that comes into play. These are 5 pictures of the same foal that were sent to me recently. And just looking at these images, I think if you were to look at any one of these images without the other images, you may make a different determination because of how the foal is standing. Here, we're right in front and it's very base narrow. We have other images where we're close to the front and it's a little bit more base wide versus the legs moving. I really want to see this foal in motion, which is going to be the thing that we're going to move on to next, because I don't have a great sense of what's going on because of the way that these pictures are set up. And I think that it can be a little bit misleading to just look at one picture at one point in time. So as I just mentioned, this brings us to our dynamic evaluation. This is best done on a firm surface with the mare being led in the foal, ideally just walking alongside it. And they're alongside a mare. Ideally, we're going to do this from both behind and in front. And what we're assessing for is how the hoof is landing, how the leg is traveling, and assessing from both the carpus level, the fetlock level, and then the back, we're looking at the hocks as well. Something important with dynamic evaluations as well is this is something that we're going to be doing serially, not a single point in time. As these foals are growing and maturing, we need to keep looking at them to see what's changing and see when and where we might need to intervene. Next, we're going to move on to talking about the hoof itself, because we can learn a lot about the hoof. This is a really great example of a foot that's been distorted, having to do with an angular limb deformity. So where these arrows are showing is to the lateral edge. This is a left hind limb for some reference, and this is looking at the lateral edge of this. I think one clear indication that this foot is not symmetric is that our coronary band is not parallel with the world here. And then when we pick up this foot, which this foal is actually under anesthesia, but if you just pick up the foot itself, you can see, looking at the height of our heels here, this side is much taller than this side, and that's called a sheared heel. And that's happened because of the way that the foal has been loading its foot because of this angular limb deformity. I don't know how well this is projecting, but there's a big dent in the side of the foot as well because of the way that this foal has been loading this foot because of the varus deformity that we have here at the fetlock. This lateral wall here is being deformed. A lot of times we're going to take radiographs on these. I think this is always indicated when we have really young foals that we suspect incomplete ossification of joints. Some of our more severe cases, we're going to be measuring some angles as well, angles at the point of the deviation, so that as we do enact treatment, we can monitor response to treatment as well before perhaps needing to get more aggressive or not. Like I spoke about before, we may be looking for fasciitis on either side as well. Next up, I want to talk about the considerations and how and when we decide to intervene. So when we're looking at these foals, we have to make a decision of, is it necessary for us to intervene, or is this foal going to correct anyways? I think in general, a lot of valgus deformities, like I said, as the foal matures and it grows up, mild valgus deformities are often going to correct themselves, whereas varus deformities often take a little bit more work on our part. I think it's also important to talk about when we need to intervene as well. This chart is handy here. It is telling us the location of the growth plate for the three major joints that I talked about. And what I'm circling here is that period of rapid growth, because it doesn't matter so much the age at which we have radiographic closure. If we're going to intervene, we want to do it in the period of rapid growth. So for our distal metacarpus or metatarsus, which is the growth plate right above the fetlock, 0 to 3 months is the rapid growth phase. So these are foals that we really want to intervene within those first few months of life before that closes. We typically say no later than 4 months to really have a significant difference for these guys. The distal radius, which is going to be related to the carpus, our rapid growth phase is 0 to 8 months. So these guys are normally weanlings heading into the yearling year when we're making a decision to intervene significantly there. And the distal tibia, 0 to 6 months, so a little bit shorter than for the carpus. And the distal tibia is related to the hock. Talking about treatment, I alluded to this in the last slide, but the art of management involves deciding which cases we need to intervene with immediately in order to have a good outcome versus those that are going to correct with conservative management. So by taking a team approach, by working with owners and farm managers and farriers and really evaluating these foals serially, so repeatedly over time, and watching how dynamic this process is, we can make the best decisions by these animals. I'm going to start by going through conservative management. So exercise confinement, and that really, this is a broad range here because it depends on how severe of a deformity we're talking about. If we're looking at our neonatal animals and they have incomplete ossification, these guys are getting locked up in a box stall. They're going to have some kind of coaptation or support on their limbs, which is a whole nother. I could do a whole nother talk just on that, so not going to delve too far into that. versus these guys that have mild to moderate deformity, and not necessarily locking them up entirely, but also not giving them full access to pasture. Like maybe they're going out in a small paddock for a few short stints a day. So they are having an opportunity to exercise, but we're not getting to the point where we're going to drive a fasciitis if we potentially have a mild deformity as we're working to correct that. Farriery and foot care is also going to be a really big part of not only our conservative management, but also when we are looking at these cases surgically, a lot of times corrective farrier techniques can be adjunctive in what we're doing surgically as well. So that's going to involve both trimming and shoeing. So looking back to hoof trimming, it's good to remember these feet are growing really fast. They are growing 15 millimeters a month, much faster than adults here. We're looking at foals that have pretty healthy feet should be trimmed every 4 weeks and should probably be evaluated by about 4 weeks of life. So farriers are going to have the best idea if there are any deformities starting. They might look at a foot and see that it's really asymmetrical and say, hey, even if the limbs are looking okay right now, I'm worried that this foal might be loading asymmetrically just based on how this foot looks. So I think getting the farrier to start interacting with the foals pretty young is important to be able to pick these up quickly. If we do have a severe deformity, these foals should probably be evaluated every 2 weeks or so. And the goal with trimming is that we're going to correct distortions and ideally restore the hoof balance. For our valgus deformities, the medial wall is going to wear quicker. And because that medial wall is going to wear quicker, they get a sheared heel where that medial heel grows taller. And we want to trim the lateral hoof on these sides versus a varus deformity, which this is jumping back to that foot that I showed you before. That lateral hoof wall wears quicker and it sends that lateral heel bulb longer. We're trimming those medial hoof walls. A lot of times we're also going to implement corrective shoeing in addition to trimming. Sometimes trimming is enough, especially if we have mild deformities and we're reaching for them early. If we have more significant deformities that we want to approach conservatively first, we may be reaching for shoeing. And our goal with shoeing really is to extend the weight-bearing surface of the foot in the direction of axial alignment. That shifts the axial load, so the load that the foal is bearing through the limb towards the extension. So here we can see that this foal has a carpal valgus. We're adding this medial extension down here, which is going to straighten out the limb. And you may see that this foal is clipped up here as well. This foal also had surgery. So this shoe extension is being used adjunctively here. Okay, I just mentioned for our valgus deformities, we're going to add a medial extension. For our varus deformities, we're going to add a lateral extension. This is a fetlock varus that we worked on. It's a little bit hard to tell, but this is a glue-on cuff that we have that has a small lateral extension on this side. This foal is pretty far out from surgery and just in a stable bandage at this point. So jumping ahead to surgical management and options for what we can use for surgery, what we recommend, and when it is indicated. There are two primary categories. We think about growth acceleration and growth retardation. There's a third category for pretty extreme cases. I'll give an example of that, but we're not going to focus so much in that realm. We talk about growth acceleration. The main surgery is a periosteal strip, also known as a periosteal transection and elevation. I put shockwave in parentheses here because it's really mimicking the goal of a periosteal strip, although it's not a surgery. For our growth retardation, we are creating a bridge across the physis to prevent growth on one side of the physis in order to correct the deformity that's happening. And some of the techniques that have been described include a screw and wire, a screw, a staple, and there are some newer ablation techniques as well. So the periosteal transection and elevation, otherwise known as the periosteal strip, just to take a step back, the periosteum is the protective layer that basically is around the bone. Think about it as a glove on the bone. It's providing bone supply, it's providing blood supply to the bone, and it's helping the bone grow in an outward direction as the bone is growing long from the growth plate. What happens here is that on the concave aspect of the limb, so on the inside of the bend, we are taking a blade and making a small incision into the periosteum, so into that little outer line of the bone, and elevating that periosteum. The goal is to release the bone and allow it to grow and stimulate it to grow in that area. These have somewhat come in and out of vogue at this point. They are pretty minimally invasive, but do still require a general anesthetic procedure. There has been some good research out there and some controlled research that shows us that a lot of these foals that have been matched with controls are going to correct themselves anyway. And in the study, it's not the best study, but it is one of the few that's out there. Just saying that this might not be doing as much as we once thought it was. Shockwave therapy, if for those of you who are familiar with shockwave, you may be familiar with it in a different perspective, perhaps thinking about soft tissue injury. Obviously, this is an adult horse here, but shockwave is essentially sound waves that are going to generate energy into those cells. They're going to stimulate microtrauma and inflammation and promote healing. So the idea is by shockwaving that same concave side of the bone, you're going to stimulate that side of the bone to grow faster. Either the periosteal strip or the shockwave you're doing right above the growth plate on the side that you want to grow faster. We're going to spend a little bit more time talking about our growth retardation. So these are going to be on the opposite side of the limb, or the side of the limb that you want to grow slower. And this image here is out of one of our main surgical textbooks and shows 4 different techniques here of growth retardation, where we're essentially creating a bridge across the physis. We're really going to focus on the one all the way to the right, which is the transphyseal screw. And what that means is that trans means we're going across the physis, so we're going across the growth plate. The other techniques here, we have a staple. This is really really quite antiquated at this point, and a plate. These procedures, the staple does not work very well. The plate is a lot of implant and is pretty invasive and creates a pretty big scar. And then I have a smaller X near the screw and wire techniques. I do still think that this is used occasionally. It is also more surgery and more implant than is needed with the screw. And it's been suggested that there are better outcomes with the screw. So there's not a ton of use for the screw and wire anymore. A new surgical technique was described a few years ago down in Hagyard, and the way that they describe it is a hemiepiphysiodesis. And what that means is essentially creating, basically having that physis just stop by drilling completely across it. They're suggesting doing this in foals where that growth potential is pretty limited. So you're looking at foals in fetlocks 4+ months, where you're probably not going to get much outcome with any of the other techniques. It's a little bit more aggressive, where they are drilling halfway across the physis in order to completely halt anything going on that side of the physis. They report good outcomes. It's not a control. It's more of a it's an intro study where there's not a lot of good control. It's more of a proof of concept, and many of the results that they reported were perceptions versus anything objective, but just to bring in something new here. I'm going to spend the bulk of the rest of the time talking about our transphyseal screws, which is truly our method of choice at this point. It is a very quick surgery. It is effective in helping correct our angular limb deformities. The cosmesis is good with these. It is a small stab incision that's less than 1 centimeter. It's a single implant that's going in, and a lot of times we can take these implants out standing as well, which minimizes any kind of morbidity on the other side. Just going to talk through what the procedure looks like in our clinic. These foals undergo general anesthesia. They're on gas anesthesia, and they're positioned on their backs. We hang both of their front legs. We clip them and we prep them aseptically. They're draped. We're fully sterile. We place a needle into the growth plate, and we take an X-ray to confirm that level. Based on the level of the needle, we make an incision a set amount above that level, and we drill a small drill tract across the physis, all guided with X-ray, and then place that single implant and close it with an internal suture, place a small bandage over, and we're oftentimes repeating this on the other side as well. Actual surgical time is just a few minutes on each leg there. This is what standard post-operative X-rays are going to look like for these transphyseal screw placements. This is in a fetlock, one of the most common ones that we do for a fetlock varus, where we are placing that transphyseal screw on the lateral side of the limb here, and it goes right down the middle of the cannon bone. Sometimes, like I mentioned, some of the things that we're going to do with the feet to help modify in an adjunctive way, we will do when the foal is under general anesthesia. This is an example of placing an extension, a lateral extension with Equilocks. Same principle as those glue-on extensions that we were talking about before. It is an exothermic reaction. It's hot. It's good to do while they're, it's a nice thing to do while they're under general anesthesia, and we can manipulate that very easily. Post-op care is pretty simple. We're going to recommend bandaging for 2 weeks. We're going home in a nice compressive bandage after surgery. It can be a pretty light bandage thereafter. We're recommending that they stay on antimicrobials because we are placing an implant. They're going to be on a pretty short course of NSAIDs. We think that there's very little pain associated with this procedure. We confine their exercise for the first couple of weeks. Post-op, we recommend serial monitoring. So again, we want to be looking at these foals really frequently to say, how are they changing? Do we need to intervene more? Do we need to be more aggressive with our farrier care? Are we getting the correction that we want? And making an informed decision as a group. Again, when do these implants need to come out? Ooh, sorry, I just almost knocked that over. Here's just another case that we were monitoring, and this chart here tells us the mean duration that the implants were left in for some common locations. So you guys probably can't read these, but these are looking at the distal cannon bone, so fetlocks, whether they were done lateral, medial, or bilateral, front forelimbs or back limbs. And we're really looking at 5 to 6 weeks, or the average time that these implants are in place. But really, it's going to be full specific, and there's actually a median. So looking at some of those time ranges will be much longer than that. Some of them will be much shorter. This is really going to depend on the foal. Implant removal is generally quick and minimally invasive. What you can see in this X-ray here, I hope, is that there is a needle that is being placed into the screw, and that's how we find the screw head. A little small local anesthetic in that spot with some sedation on board, make a stab incision in and take that implant out. When we're talking about outside of fetlocks, forelimbs, this is something that's pretty easy to do on farm. Occasionally, we will have to do a brief injectable anesthesia if we're talking about hind limbs, medial limbs, or any concerns there, but usually quite simple and quick. It's important to talk about surgical complications that can happen. Sorry, we jumped ahead there. Apologies. So surgical site infections that can be localized to the skin and the subcutaneous tissue, but we always worry when we have an implant in there, anytime that we are suspicious of an infection that would look like any drainage from that site, swelling, heat, any of our infectious biomarkers that are elevated, we want to get that implant out because ultimately that's going to be the key to clearing up that infection. So sometimes we're riding out time to try and get that correction that we want, but also want to make sure that we're not potentiating an infection in the bone there as well. When taking these out, the screw heads can get stripped. This will require some additional instrumentation to get that screw out, and we generally do that under a quick anesthetic as well. Screws can unfortunately break. We also have instrumentation to get that out. It is a bit more invasive, and that can happen. And then this is a pretty extreme example here. I hope you can all see. It's an example of overcorrection where basically a foal was under treatment surgically for an angular limb deformity. It initially, despite looking at this limb now, it might be hard to believe that this horse had a carpal valgus deformation, was treated with a screw placed on in this carpus and was basically just not monitored for a pretty significant period of time after and represented. And you can see not only do we have a deviation of the carpus, but you can see just the way that the entire hoof is shaped at this point, that the entire leg has compensated. So this is a really extreme example, but it's I think a good way to understand why it's important to monitor and make sure that we're getting these implants out at the appropriate time. This is a before and after case, pretty typical of what we're looking at. So foal is walking alongside the mare here with a dynamic evaluation, has a pretty significant fetlock varus on the left, a little bit more moderate on the right. Bilateral transphyseal screws were placed in the fetlocks up front. This is the before static image, this is the after, and this is the after video. Just before screw removal on that video. So looking at outcomes, I think I mentioned this a few times, angular limb deformities are something that's tricky to study, and there's not a ton in the literature. There's so much subjectivity that goes into it in deciding how we are measuring, how we're creating objective measurements to be able to have data is challenging. But some people have tried to have something meaningful to put forward to say these things are worth doing. So looking at racing and sales performance after transphyseal screw placement, and these are specifically for carpal deviations and thoroughbreds, what this paper finds is that there was actually no statistical difference between racing and sales performance, and they were looking at maternal controls. So foals from the same dam from different years that did not have any management for angular limb deformities. And while there were no differences in racing and sales performances, they did say that it was thought to have a positive influence on both the conformation and limb motion as viewed by a potential buyer, with very minimal cosmetic consequences and very few complications. So generally supportive of this procedure. This is another paper that talks about transphyseal screw placement as a technique and talks about efficiency, that speed of correction is going to be faster than for any of the other surgical modalities. The cosmesis is excellent, and increased rate of correction when compared to screws and wires specifically. Essentially just need to monitor for overcorrection in those postoperative assessments. I mentioned that I would bring up a pretty extreme case as well. This is looking at an angular limb deformity in the middle of a long bone. So this is a quite severe case, and it's more of a wow factor than anything. And this could be indication for either what we call an ostectomy, where we're cutting away a part of this long bone and recreating it. This is another indication for this type of surgery would be if we have a really severe angular limb deformity that's not managed prior to those growth plates closing. So once those growth plates close, we can't really manipulate it any other way. This is, like I said, this is a wow factor. To go into this type of surgery would be an extremely involved process. That would be a lot to ask of the animal, a lot to ask of the client, and probably not looking at a great athletic prognosis on the other side. But at the same time, these things are described, and sometimes it's worth mentioning the wow factor things as well. So just to review some take-home points, when we're talking about angular limbs, we really need to focus on a team approach. So when it comes to the farm manager, when it comes to the owner, when it comes to the farrier, when it comes to the veterinary team, that may be a farm vet, that may be a surgeon, it's going to be multiple people. And I think everyone really communicating as to what's going on and making sure that we're all looking ahead to what the best outcome is going to be and intervening at appropriate times. Having realistic goals for the really severe cases is important. Like I mentioned, the varus deformities are the ones that are unlikely to correct themselves as the foal naturally matures in size. So those are the ones that we need to be more proactive for in general. It's important to be diligent in monitoring progress or lack thereof. So the serial evaluations, continuing to look at these foals, getting them out of their stall, doing a static evaluation, doing a dynamic evaluation, perhaps videoing that so you have a library to compare to every 1 to 2 weeks when they're young. It's a really dynamic process. And lastly, remaining cognizant of the foal's age and what those timeframes are for where we're going to have that maximal growth potential across our growth plates and where we're going to be able to make the most correction.
Hi, everyone. I'm Dr. Laura Jevsikas. I'm the internal medicine specialist at Rhinebeck Equine. I know a lot of you in the room and online. So thank you again for coming. We really enjoy putting on this day. And thank you again to our sponsors. And stick around for the panel at the end. Don't go anywhere yet. Today, so I often talk about neonatal foal issues. This year, I'm going to jump to Reproduction equi because it's something that many of you have to deal with on a regular basis. And there is a little bit of new information, although spoiler alert, nothing groundbreaking new to treat this problem. So let's see. That worked. Okay, I can do that. Okay, so what I'm going to talk about today is Rhodococcus equine pneumonia. And we're going to go through the clinical manifestations, meaning the symptoms that we see with it, epidemiology, where this disease comes from, why we see it in some horses and not others, diagnosis, control, and therapy. It's a lot to go through. So, and this isn't working. Okay, we'll do that. Okay, so what is Rhodococcus? Rhodococcus is an intracellular bacteria, which is really important when you talk about why it can be hard to treat. It's a very important cause of pneumonia in foals between 3 weeks and 5 months of age, and it does also affect immunocompromised people. It's present in the environment of almost every horse farm, but the clinical disease can be absent, sporadic, or endemic on any given farm. And I would bet that in this room, we have representatives of all of those different groups. And one thing I really want to make sure everyone leaves today understanding is that subclinical infections are really, really common and often do not require any form of treatment. However, Rhodococcus is really important because it's a significant source of economic loss to our breeding population. And while it can result in, we can lose foals, fortunately, the mortality rate is relatively low. However, morbidity, meaning the proportion of foals that get sick, can be quite high. And there's a lot of money that goes into treating the sick foals and preventing foals from getting sick in the first place. So when we think about the different clinical manifestations, this is what we think about when we think of the pneumonia form, which is the most common cause. It is technically a pyogranulomatous bronchopneumonia with abscessation. So these are the nice, you can't see my clicker. These are the nice abscesses here, quite obvious in this picture. Clinical signs that we might see with that would include fever, dyspnea, meaning difficulty breathing, increased respiratory rate or effort, cough, although a lot of these foals never cough or don't cough significantly, even with really severe disease, and then ill thrift. They may just not be gaining weight properly, have a poor hair coat. There are a whole lot of what we call extrapulmonary disorders with Rhodococcus. So when Rhodococcus goes places other than the lungs, and these are important for a few reasons. One, I really want you to be aware of them because if you see any of these signs, it's a trigger to make your vet aware because then we need to look at their lungs and investigate further and make sure they're on proper treatment. But also because if they have extrapulmonary disorders, there's a nice retrospective paper showing that their prognosis is significantly worse than foals that just have Rhodococcus in their lungs. So, sorry, I forgot to actually talk about that one. So one that we see relatively commonly are abdominal abscesses. So the bacteria can go to the lymph nodes. These are the lymph nodes running along the colon here. And the bacteria can cause infection there. And we'll often see large solitary abscesses within the abdomen. Depending on the size, if they're over 8 centimeters, the prognosis is really quite poor. And that is because what tends to happen is that abscess gets very sticky. This picture down in the bottom right is a picture of all of the intestines adhered to that sticky abscess. So prognosis for that, even with very invasive surgical drainage, which is what's shown here, is really quite poor, unfortunately. And these foals tend to have very, very high white blood cell counts as well. We also see a lot of musculoskeletal problems in foals with Rhodococcus. So some may just have a simple synovitis. So these foals have swollen joints, similar to what you might see with an OCD lesion. They are typically not lame. However, they can also have an actual infection set up in the joint itself. And this is a much more concerning situation if they end up with an osteomyelitis or bone infection. And these infections are generally much more challenging to treat than the pneumonia form. Another thing that may be more obvious to you just in your daily examination of the foal is that their eyes may turn yellow or green if they have secondary uveitis. And this is from their immune system being overstimulated. The prognosis for vision and for their eyes to recover is usually quite good. I make sure these foals don't have ulcers, and then I'm treating them with topical steroids and systemic anti-inflammatories. But this, again, should just be a signal that we need to go and look at their lungs. One I never like to see, you can tell this is quite an old picture, but this is a really bad deal, is they can also have abscesses in their vertebral bodies along their spinal cord. So this is the spinal cord right here, and there's this big abscess in the bone compressing the spinal cord. So this foal is paralyzed in its hind end because of that compression. Not something that we're very capable of treating, unfortunately. And then we also see some fun abnormalities on their blood work sometimes. So this was a foal we had in the clinic last summer, who had rhodococcus in her lungs, her bone, her abdomen, and she also came in with severe anemia and thrombocytopenia, or a low platelet count. So it's hard to read on here, but her PCV, for those of you who are familiar, is about 18%. It should be close to 35 or to 40%. That was the severe anemia, and her platelet count, she had 40,000 platelets, so that should be close to 1,000, or sorry, 100,000. That part of her disease did actually respond pretty nicely to steroids. So we're going to switch gears and talk about epidemiology briefly. So this is sort of how the agent, meaning the bacteria, the host, the foal, and the environment, your farms, all interact to set these foals up for this disease. So important to understand that just because the bacteria rhodococcus is, sorry, trigger happy here. The bacteria rhodococcus is present on farms. It's probably present on your farm. It may not be the virulent form of the bacteria. So this plasmid called the VAP-A plasmid is present in the virulent form of the disease. And so this was my mentor, Dr. Jagir's PhD project, actually. And so what he showed is that if this plasmid was present, then foals experimentally would develop classic rhodococcus equine pneumonia, whereas if it was rhodococcus without this VAP-A plasmid, which is just a genetic variation in that bacteria, then they would not go on to develop pneumonia. And this is now really important now that we do a lot of diagnostics using things like PCR as well. So bottom line is not all rhodococcus is created equally, and it needs to have that VAP-A plasmid to be infectious and cause pneumonia. Other things about the bacteria. Most of the rhodococcus comes from the intestine. Most of the rhodococcus that comes from the intestine and the environment of horses does not contain those plasmids. So again, just because it's there doesn't mean it's necessarily going to cause pneumonia. I often am asked the question of, I'm looking at buying a farm. Should I test the soil? Should I be afraid if there were horses there before? None of that's really going to be helpful. You just accept that there's probably rhodococcus on any farm. And there really is no evidence of farm-specific strains that has been shown. Horses that carry the archaea in their intestine, in adult horses, it is just carried passively, meaning it's just literally passing through them. They're spreading it on the pastures, but it's just passing through, not causing any problems. In foals, the bacteria does actively multiply and cause infection. So adult horses are immune to it and don't have the same issues as our foals do. The pneumonic foals, the ones with the virulent VAP-A plasmid carrying bacteria, are the major sources of contamination of the environment with the virulent archaea. So what about your farm characteristics? So factors that have been associated with higher risk for developing archaea pneumonia include large acreage, high foal density, population of transient mares and foals, so horses coming and going on the farm, housing foals in stalls as opposed to just outside. But overall, it was not associated with poor management. So things like a dirty environment really was not specifically associated with the development of pneumonia, but high density definitely is. So in terms of the soil-borne rhodococcus, the concentration of rhodococcus and virulent rhodococcus are not significantly different on farms with or without rhodococcus pneumonia in their foals. And it is not significantly associated with the rate of occurrence of pneumonia. So the soil-borne is not as important as the airborne. So in contrast to the soil-borne bacteria, the concentration of virulent Rhodococcus in air samples was higher at farms with affected foals compared to farms that did not have affected foals. And not surprisingly, the concentration was higher in air samples from barns relative to pastures, right? I mean, sometimes we have to study things that are obvious just to say that it's true, but they were able to show that. So bottom line is airborne concentrations of virulent R. equi may be an important determinant of foals developing Rhodococcus pneumonia on any given farm. So just think about that in terms of ventilation in your barns, how much your foals are inside versus outside, all those things can play a role. So mares as a source of Rhodococcus. So all mares at endemic farms tend to shed virulent R. equi. However, the fecal concentration of virulent R. equi was not directly associated with a risk of pneumonia in their given foal. So overall, it's thought that mares are an important source, but not necessarily to their specific foal. So in other words, they may be contaminating the environment, but it's not a guarantee that their foal will be affected, which is likely because of genetic factors as well. The host, so the foal is, so foal's immune system is of critical importance, as Dr. Gregg was talking about before. Our foals have immature immune systems, and how their individual immune system deals with exposure to Rhodococcus is of utmost importance to whether or not they develop the disease. However, we still don't know a lot about how to tell which foals are going to develop the disease and which aren't, and exactly what parts of the immune system that we can manipulate in an effective way to help prevent infection are out there. So this is an area I'm sure we'll have more information on in the future, but for now, we just have to accept that that's the way it is. So we're going to switch gears and talk about diagnosis. Blood tests are really not specific for infection with Rhodococcus. So high white blood cell count and high fibrinogen. Foals with Rhodococcus tend to have a higher white count and fibrinogen, but it's not specific at all. So that foal could have an infection with any other kind of bacteria in their lungs. They could have an infection elsewhere. So it's not telling you specifically that Rhodococcus is the problem. It may just be indicating that the foal is sick. Serum amyloid A is a test that we now use quite frequently. We have stall side testing available. It would be really great if it was helpful at the diagnosis of Rhodococcus, but unfortunately, it's really not. So once these abscesses form and the infection is walled off, the SAA tends to drop very quickly, which is true in any disease process where you have walled off infection. The SAA tends to not be increased as long as the fibrinogen is. So it's really not helpful for making a specific diagnosis of Rhodococcus. Ultrasound. So ultrasound is a really great tool. It is very easily performed in the field. We can do this ultrasound with a tendon probe, a rectal probe. It's quite, the lesions tend to be superficial. We can see them very easily, quick, easy, non-invasive. Again, though, these lesions are suggestive of Rhodococcus, but you're not getting a specific, you can't say for sure that it is Rhodococcus, and you don't know what antibiotics that bacteria is susceptible to. So this top picture is a very classic, this I would actually call an abscess because I can see this wall. So from here to here is the wall. Sorry, this is the foal's body wall here. This is looking between the rib spaces. This is all muscle here. This bright white line here is the surface of the lungs. And then we have this abscess right here. This is the same idea. We were at a more depth here. But you can see a smaller abscess here. And then what we're doing is measuring the diameter of the abscess, which I'll talk about a little bit later. So if you see lesions like this in a foal of an appropriate age, especially if it's from a farm that has a history of Rhodococcus, we often assume, rightfully so, that this is most likely Rhodococcus. But we really don't know much about the characteristics of that specific infection in that foal without doing things like a transtracheal wash. Radiographs can also be really helpful as an adjunctive diagnostic tool because unlike ultrasound, which just shows us the surface of the lungs, the radiographs allow us to penetrate through the foal's entire chest. And sometimes they will have very deep abscesses that don't communicate with the surface of the lungs. And so we may miss those, or at least severely underestimate the severity of the disease without doing radiographs as well. So this picture on the right is very classic for rhodococcus. I was trained to look at these as Easter basket lesions. So if you can appreciate, there's sort of a circle here and there's a line here. This line is actually the gas fluid cap in an abscess. So the little capsule here is the Easter basket handle. And then you've got your gas dorsal and your fluid, which is pus, ventrally. So really, the way to get a definitive diagnosis of Rhodococcus equi or any type of pneumonia is a transtracheal wash. So this is a procedure that we do quite commonly in the field. The folds are sedated, standing. I go in through between the tracheal rings so that I'm not getting a sample that's contaminated by upper airway bacteria. I take a sample of the pus from their trachea, which is generally a pooled sample from all of the infected lung fields. And with that sample, we can do a number of things. Most important is culture. So that's going to identify that, yes, it is rhodococcus, or no, it is not. And that is what gives us our antibiotic susceptibility testing. So we get our culture and sensitivity. Those results typically take 3 to 5 days to get back. So we never are withholding treatment while waiting for those results. But it is really, really important, and we'll talk about resistance in a little while. The other thing we can do, which gives us much faster information, is cytology. So that shows us what type of bacteria is there. Is it gram-positive? Is it gram-negative? What is the shape of that bacteria? So rhodococcus is a gram-positive coccobacilli. This is a gram stain of cytology of a foal with rhodococcus, and these little guys are the bacteria here. The other thing that we can do is PCR testing. So this PCR is looking for that virulence plasmid, the VAP-A gene in that sample. I really only do this in very rare cases because usually I'm much more interested in the antibiotic sensitivity and this identification is telling me that it's rhodococcus. So I really only do this in cases where nothing rose, but I think that I'm really suspicious that rhodococcus is there, or I need to do further investigating for some reason, but I'm not doing this right off the bat, and it's a waste of money in most of these foals that I see. So that's diagnosis. We're going to talk about control because this is really where a lot of our efforts are focused on farms with endemic rhodococcus. So the three main approaches to controlling these infections, because we're not going to rid it from the environment, it's just not possible. So decreasing the size of the infective challenge, early identification of clinically affected or infected foals, and hyperimmune plasma. So if we could just have all of our foals grow up in a little bubble, they would be fine. Really, they wouldn't develop immunity, as Dr. Craig was talking about. They just have problems later on, but it's good to keep that in the back of your mind. So things we can do to decrease the size of the infective challenge, pasture rotation, decreasing the stocking density of horses on your farm, pasture irrigation, isolation, and then isolation of pneumonic foals. So just to talk about the pastures again, so as many of you in this room are aware, we tend to not really see clinical rhodococcus on a yearly basis until we get to hot, dry weather. And so it's out there in the environment. When they're stirring up dust in the fields, it becomes airborne, they breathe it in. So anything we can do to keep the pasture condition as pristine as possible can be helpful. And then in an ideal world, we would isolate foals that we know have rhodococcus and are clinically affected with it because they are shedding that virulent rhodococcus. It is very impractical to do that in most situations, but just something to keep in mind if you have a smaller farm that has not had a lot of rhodococcus problems in the past, it may be something you want to consider. So earlier recognition of the disease. So the three main ways to do this are monitoring body temperature and just the condition of the foal, ultrasonography, and then blood work. We're going to talk about all of those. So I am a huge fan of daily temperature taking in foals, not just for rhodococcus, just as a general way to check on your foals. It's also just part of doing a daily physical exam of that foal. Are they looking quiet? Are they dumpy? Do they have yellow eyes? Are they breathing harder than usual? All those sorts of things. So we have a few new techniques for doing this, which are really helpful. So yes, you can have a rapid read thermometer and wrestle with your foals. But now many of our breeds require these foals to be microchipped, and the biothermal microchips can be really, really handy with large populations with lots of foals. It requires less handling of the foal. You don't have to stick anything up their bum. It reads their temperature from the microchip that they need anyway. So, and it's really nice because it also keeps a nice chart for you of that individual's normal temperatures, because just like us, they all have sort of their normal variation. So you can see if anything is out of the norm with that. This is actually a chart from, and I'm sure you can't see any of the numbers, but this was actually a chart looking at body temperature with regular thermometer, rectal temperature versus the microchips. But really what I wanted to use this to demonstrate is that if you're only able to take your foals or any of your horses' temperatures once a day, I really recommend doing it later in the day, because just naturally their temperature tends to go up later in the day. And so when they have fevers, we see it most often late in the day. So their temp, ideally twice a day is great, but if you can only do it once a day, I would recommend the afternoon or evening. So just in terms of rhodococcus though, taking their temperature again is not going to be specific at all. That's just indicating to you that the foal might be sick with something, but you don't know yet what it is. However, that may stimulate you to want to do further diagnostics such as ultrasound. So we can use ultrasound for screening as well as to help support our diagnosis. So when I finished vet school, just a long time ago now, this was really becoming, this was the in thing. It was great because foals could be screened. We could catch the infection early. You could see the abscesses quite readily and start them on treatment. And so the recommended protocol, typically every 1 to 2 weeks, starting at 2 to 4 weeks of age until they're 5 months old. It is labor intensive, but it does allow for early recognition and treatment. And it does decrease mortality farms. However, what we now know is that used alone, this promotes unnecessary treatment of foals with subclinical disease and promotes bacterial, antibacterial resistance, because really what we're seeing a lot of times, if these foals have no other symptoms and you're scanning them and you find these abscesses, we know that about 70% of foals in that situation, so no other signs, just abscesses on ultrasound, will resolve without any treatment. And so if we weren't looking, they would go ahead and get better. So yes, it did allow us to catch the foals that were going to go on and get sick earlier. And so in the short term, it seemed like a great thing, but we now know that long term, we're shooting ourselves in the foot because we don't have a lot of drug options. So again, what we do when we, let's say, we're scanning between the rib spaces, what we've started looking at is the abscess score, so which is really just the cumulative diameter of all of the abscesses. So this, you can't read these numbers, but this is about a 1.5 centimeter abscess. So if you have 3 of these, if you have 2 of these, then you have an abscess score of 3, right? So you may have 1 10 centimeter abscess or 5 2 centimeter abscesses, and the score is the same. I'm really good at math. So. Okay, so what about blood work? And this is from a screening perspective. So thinking about, okay, if we run blood work on them regularly, can we catch them early on in the disease process? Again, it's not very sensitive or specific. So I'm actually just going to skip to the next slide. So they've looked at white blood cell count and fibrinogen. And again, if they have a high white blood cell count and high fibrinogen, they're more likely to have rhodococcus. What's called the positive predictive value, meaning how good is that test at predicting that they actually have the disease you're looking for. That does go up if you're on an endemic farm with rhodococcus. The positive predictive value at a cutoff of 15,000 white cells is pretty decent. So 85%. So the higher the white count is in a situation with endemic disease, it can be helpful. However, to me, that's just saying, okay, that's a foal. We should go and scan its lungs and see what's going on. SAA, again, not very useful for screening either. So this study did look at measuring SAA every 2 weeks, and it's possible that if we did SAA every day, we might catch those when the SAA goes up early on in the course of the disease. But most people don't want to run this test that frequently. So this study does have limitations because of the timing. Overall, detected 56% of foals prior to the development of clinical signs. And again, that's not eliminating those foals that may go on to clear the infection on their own. All right, plasma. So hyperimmune plasma has been around for a long time now. There are many different plasma companies. I'm not going to get into that at all. We're just going to all of the hyperimmune plasma comes from horses that are vaccinated against REQI. So you may be asking, well, if those horses are vaccinated against REQI, why can't we just vaccinate everything? Well, the vaccines are not effective at preventing the disease. Because this bacteria is intracellular, the ability of vaccines and antibodies to help prevent the disease is limited, which is our limitation with plasma overall. So plasma can be easily performed in the field. It is labor intensive. It is not without risk. We do see reactions to plasma, but knock on wood, it is really uncommon. So there are a number of studies looking at plasma in field conditions. Any studies looking at rhodococcus, anything related to rhodococcus in a field study is really challenging because, as many of you are aware, some years are bad rhodococcus years and some years are better. And so it's really hard to pick out what is just the normal year-to-year variation and what is actually an effect of the plasma or whatever treatment we're looking at. So with experimental, sorry, I got ahead of myself because these two studies are not field studies. This is the experimental challenge with rhodococcus, which is easier to control for. So plasma has been shown to decrease the number of rhodococcus organisms in the lungs. And to decrease the incidence of clinical pneumonia after experimental challenge. So that's good. That's a pro in the plasma. These are the controlled field studies. So many of these this goes back to 91. So quite old. And overall, you can see, and so these are not all the same type of hyperimmune plasma. Lots of different variables here, but overall, one of these studies showed a statistically significant difference in the incidence of rhodococcus in foals that got plasma. So that's not overwhelmingly encouraging. But overall, in field studies, 30 to 40% reduction in the incidence, not statistically significant, but there is a reduction in the incidence of disease. So as I was just saying, the antibody is not sufficient for complete protection. If we can get anti-VAP-A antibodies, so it's specific to that virulent plasmid, that is more helpful to confer protection. However, what also gets confusing is that there's variability in the products themselves. So even amongst the same brand of plasma, if you take bag A and bag B, the amount of antibodies in those bags can vary. And then the amount in the foals post-transfusion can also vary. So it's a very hard thing to have a reliable response to and to create a good study for. So this is not something, it is not a magic bullet, and we definitely cannot rely on it alone. So it has to be combined with other control strategies. So other things we've looked at to sort of try to make plasma more effective is when should the plasma be given? So we know that foals are exposed to rhodococcus from a very early age, and most of them are infected within the first month of life. We really want that plasma to be on board before exposure. And so the most commonly suggested approach is to give plasma within 48 hours. It used to be more common that we would recommend giving a second liter around 25 days of age, 1 month of age. But now we've shifted more to maybe giving that the 2 liters right off the bat, as opposed to at birth and 1 month of age, which is where we get into quantity. So there have been a few studies looking at the amount of plasma that is given. And in this study, they did see a reduced incidence of, this is subclinical pneumonia. So again, 70% of those don't need treatment anyway, but reduced incidence of subclinical pneumonia, in other words, developing abscesses on ultrasound when 2 liters of plasma was given as opposed to no plasma or 1 liter. Another retrospective study showed a 2.4 times higher odds ratio of developing clinical pneumonia in foals that received, that's the wrong direction, sorry. Foals that received 1 versus 2 liters. So in other words, if they only got 1 liter, they were 2.5 times more likely to develop clinical pneumonia compared to getting 2 liters. So supportive of giving a higher volume. And then in a prospective study, the odds of developing clinical or subclinical pneumonia were inversely related to the amount of antibodies, meaning that the higher quantities of antibodies were protective against developing clinical disease. And I care a lot more about the clinical disease than the subclinical. So the bottom line on plasma, so plasma, it's expensive to give. And so I think it's really, there's no one size fits all. It really you have to look at your farm situation and how much rhodococcus you have, where you want to be spending your money. So in most practices, 2 liters of rhodococcus plasma is going to cost between about $800 and $1,100 per foal. Treatment on average is going to cost between $300 and $700 per foal. But that's assuming that they respond to treatment. So we can talk about treatment now. The mainstay of treatment is still macrolide antibiotics. This is a class of antibiotic that concentrates in the white blood cells in the lungs where the bacteria live in the lungs. So rhodococcus goes to the macrophages. If it has the VAP-A plasma, the macrophages can't kill it as it would without that plasmid. And these antibiotics concentrate to very, very high levels right into those cells. So it's great in the lungs. The reason I keep qualifying in the lungs is if you think back to all those extrapulmonary disorders, those same antibiotics may not be as effective in all of those other body parts. The bone especially is really hard, and those intra-abdominal abscesses as in the lungs. And so we are typically combining this with rifampin, which also, because of the characteristics of that antibiotic, can get inside the cell. Good for intracellular treatment. So 3 to 4 weeks of treatment is typical. These folks don't respond super quickly. So macrolide and rifampin, there's a few different combinations. Azithromycin and rifampin, clarithromycin and rifampin are the 2 combinations that we use. Clarithromycin and rifampin has been shown to be the most effective, and that is still my go-to starting place for treatment before I have culture results if I have taken a culture. Side effects are important to think about with these drugs. Diarrhea is pretty common. A lot of times it's fairly self-limiting. I will give that full few days as long as they're staying hydrated. They may need fluids for a day or 2, but that's usually pretty rare. A lot of them, they will improve within a few days, and we are able to keep them on the antibiotic and not switch. Hyperthermia. So the macrolides do cause hyperthermia because they actually prevent sweating in these foals. It is most profound with erythromycin, which is the oldest of the macrolide antibiotics that we really don't use anymore because it's not as effective and the side effects are more. But this is why the recommendation is frequently made to not have foals that are on these medications out during the day in the summer, which is of course when they have the infection. So, but it's really because that prevents them from sweating. Clarithromycin has the least profound effect on sweating. So lots of other antibiotics that have been looked at. So there are injectable macrolides. These are really medications that come from the cattle side of things. So gamithromycin, telithromycin, telithromycin. We really don't have efficacy data for rhodococcus. And they are a bit scary to me because they are long acting. So a lot of these are given once a week. And that can be a really good thing because it's really convenient, but it also means that if they have side effects or have any problems with it, then you can't withdraw that medication. And there are significant side effects reported with most of these, including like acute death. So we'll try to avoid that if we can. So doxycycline is something we use quite a bit of, and that is really because in foals that have resistant rhodococcus, it's very common they are resistant to the macrolides and rifampin, but may still be susceptible to the tetracyclines, doxycycline or minocycline. We do have pharmacokinetic data, meaning we know what doses to use, and those are supportive for treatment of rhodococcus. We often still use it in combination with rifampin unless we have evidence that that particular foal has resistance. So, but we don't have any long-term efficacy data for rhodococcus specifically. Gentamicin is interesting because rhodococcus is generally susceptible to gentamicin. However, we would have to give it, in order to get the concentrations in the cells where the rhodococcus is in the lungs, we would have to give it at such high doses systemically that it would cause permanent kidney damage, which is a common side effect of that medication. So we can't give it at a dose that's safe for the kidneys, but kills the rhodococcus when we give it systemically. So now what we have turned to is giving this with a nebulizer. So we're getting higher concentrations within the lung, and that can be effective. I never use that as monotherapy, meaning I'm always using that in combination with other systemic medications, but it can be helpful in some of these foals with severe infections or that are not responding or with resistance. So supportive treatment. So I see all the worst cases every summer that come into the hospital, and we can help them out significantly. They can be on intranasal oxygen if needed, if they're really not oxygenating well, which is quite common if their pneumonia is bad enough. We can also, give nonsteroidals as needed while monitoring kidney values and protein, fluids to keep them hydrated, as well as keeping them in air conditioning for their environment. And then giving the nebulized medications, antibiotics, and bronchodilators. So I will try to speed up. Miranda's giving me the hook, but we just need to think about which foals should be treated. So based on the Havemeyer Symposium meeting last summer, the criteria that they came up with was foals that have an abscess score of greater than 20 centimeters. So again, that's that cumulative diameter of all of the abscesses. A fever of over 103 for 2 days and pulmonary abscesses, or if they're dyspneic and have pulmonary abscesses. To me, it really just needs to be a case-by-case basis, looking at the individual foal, the farm situation, and how they are doing clinically. So why do we just not treat all the foals with abscesses on the ultrasound? Most foals, number one reason, most foals with subclinical infection recover without treatment. We talked about that. So this is just mentioning specifically the studies in Germany that were done showing this. So they had groups of foals they were scanning all the foals, doing blood work and exams on all the foals, and then treating some with different combinations of antibiotics and some with placebo. Over the course of 2 years with 2 studies, 43 to 88% of foals in the placebo group recovered without any treatment at all. And the proportion of foals that had disease progression did not differ between groups with or without antibiotics. And the duration of therapy was significantly less with azithromycin rifampin versus placebo. So they did get better faster, but a lot of them didn't need treatment. The number 2 reason is the overuse of antibiotics to treat subclinical disease, promoting antibiotic resistance. I will go through this quickly, but basically, this is a study that was done looking at a large farm in central Kentucky, where they started doing serial ultrasounds in 2001. In 2010, they identified 9 macrolide rifampin-resistant rhodococcus isolates, and started doing air samples and retrospective data collection. In 2011, they started doing prospective cultures, pre and post treatment. And I'm just going to skip to the results because you can't read that anyway. By 2011, there were 132 foals on the farm. 27 to 20% had Ultrasonographic evidence of pulmonary disease, rotococcus was confirmed in 93% of those. Pre-treatment, 24% were resistant. They're treated with clarithromycin rifampin. Post-treatment, 62% were now resistant. All the foals in that year survived, so none of them were super sick. But the resistance is a really big deal because we really don't have a lot of antibiotics to turn to other than these groups of antibiotics. And if they're resistant to one macrolide, they're resistant to all of them. So we really need to be cognizant about how we're using antibiotics in this population. In terms of the response to treatment, the first thing I look for improvement in is their temperature. Respiratory rate and effort we want to be monitoring. Ultrasonographic size of the lesions is going to decrease, but that decreases slowly. I'm much more interested in what their temperature is doing. White blood cell count and fibrinogen also tend to decrease really, really slowly. So in terms of when I take these foals off treatment, I'm really looking for them. They're all, if I really think they have clinical disease, they're going to be on antibiotics at least 3 weeks. Ideally, we're scanning them again. And I want to see that those pulmonary abscesses may not be completely resolved, but at least are drastically reduced in size and the foal is doing well clinically before we think about stopping antibiotics. So take-home points, monitor closely, but avoid unnecessary treatment because we need to think about resistance. Ultrasound alone as a screening tool results in overtreatment. Think about your farm conditions, especially air quality, and then cost-benefit analysis by farm and or individual foal in terms of plasma administration. Trach washes are always helpful, so that's how I know if they're dealing with resistant bacteria. And I may not do it right off the bat. I don't do it right off the bat in most foals, but if they're not responding to therapy, then that's a great time to do a trach wash and see if there's another bacteria there or if they're resistant and try to figure out if they're not responding to the antibiotics that they're on because they have a resistant bug, or if there are other things going on. Thank you. This is our first 2024 NICU survivor right there. So.
I have a 17-year-old thoroughbred mare that has quite a few cysts. Tried twice last year to get her in foal with no luck, and she's always been quite easy to get in foal. Are the cysts affecting her fertility? So I think start with Dr. King, since she was our expert on the aged mare, treating the aged mare.
So I guess the first thing I would want to know is how big are the cysts and where are they located? So they certainly could be affecting her fertility, but more likely those cysts are sort of an indication that something is going wrong with the uterus. And so what I would recommend doing next is taking a biopsy and evaluating the overall health of the uterus, and then taking steps from there to determine, if there's anything that can be done to improve her reproductive health.
Awesome. Would you say that when you guys, including Dr. Pash here, when you guys are looking at the presence of cysts, are there locations where the cysts might land or might be present in the uterus that make you more likely to want to have them removed?
Definitely, yes. So if they are located in the bifurcation of the horns, that's where the embryo is going to sit. And so those cysts tend to interfere a lot more with pregnancy than when they're in other locations. Sometimes if they're right in front of the cervix or right in front of the oviduct, they can kind of obstruct embryo movement there for fluid drainage or necessary physiological processes. But for the most part, smaller cysts are not too much of a problem in my experience.
I would agree 100%.
Are there any supplements that you have found are beneficial for stallions? What do you recommend?
So conveniently, we have a rep here from Platinum, but Platinum Performance is my go-to for stallion supplements, and their employees are really good at helping sort of tailor the correct supplement plan to a stallion given problems. They also have some products that are just going to be beneficial in general with things like the omega-3 fatty acids. But Platinum is They have a very good range of, I think, proven fertility supplements for mares and stallions. And it's very user-friendly as well.
How does oxytocin work? Or can you talk about like what is oxytocin and what does it do?
So basically, and it's a hormone that acts on there's receptors in the muscles of the uterus. And when they're stimulated when those receptors are stimulated, they cause the uterus to contract. And if the dosage of oxytocin is correct, either, the mare's own endogenous oxytocin, or if we're administering oxytocin, if we're doing it at the right dosage, it causes those muscles to contract in sort of a wave form. So they are kind of pushing things out through the cervix. So it's a very coordinated muscular contraction. If we give too much oxytocin, it will stimulate all of the receptors at once and cause that uterus to go into a spasm. So that's not ideal. But oxytocin is released during the estrous cycle to help with fluid drainage, and it's also released during foaling to help those muscles contract and expel the foal, basically.
Can you please elaborate on why you would choose to use a modified live versus killed version of the flu vaccine when the foal is 10 to 12 months old?
You bet. So the modified live is just a different way of presenting the antigen to the immune system. So there's several different branches of the immune system. And with the modified live, we're applying it intranasally. So it goes to the mucosa. So the mucosal immune system, which is responsible for the first wave of defense when a respiratory virus comes into the respiratory tract. So when we use that modified live, we make a more robust defense against that entry point. So it's just a different arm of that immune system, giving us another barrier to prevent disease.
When you are vaccinating foals, do you typically, I think the question is, do you recommend a three-way or a four-way? Like, what are your thoughts? I'd like to hear what your recommendation would be when you're vaccinating foals. And then I think we should all share what our thoughts are on what we use for vaccinating foals.
So I tend to gravitate to as few sticks as I can in a foal, especially as I get older. Once they get bigger than me and my help. So I like a large combo. If I can use a large combo, and then plus a rabies, I can get basically everything in 2 sticks. So that's kind of my go-to.
I would agree with that.
I agree. I was worried you were going to give some answer about the most effective thing. I just go for the least number of shots.
Yeah, foals don't like needles.
Yeah.
How long would a new horse be quarantined and how far apart from other horses? I mean, I think that's kind of, well, I think it's farm specific, right? I mean, ideally, it's quarantined so that, what was the distance? I mean, you don't want them to be able to obviously touch nose to nose.
Yeah, so the flu can travel 50 yards pretty easily. So I would want at least 50 yards.
50 yards. Okay.
And I like 2 weeks quarantine, dealing with daily exams and temps in the evening and with your biothermal microchip.
What about Dr. Javsikas? What about like any of the stuff that you would utilize to like lead the horse or groom the horse or clean the stalls? Like, what does quarantine mean to you?
Yeah, so ideally each horse would have a dedicated set of grooming supplies, stall cleaning equipment, or that equipment should be cleaned. You can make a bucket of disinfectant that pitchforks can go into afterwards. It depends a little bit on if we're dealing with quarantine and what diseases we're worried about, but those are good practices. Certainly people's hands are the best way to transmit things. So just disposable exam gloves between horses can be really helpful.
So I think this is a question that relates more to stallions. How long is optimal between live cover? And maybe it's actually they're asking the question about when should it be between covers for the mare to optimize fertility. But I think probably from the stallion perspective, Dr. Pash, what are your thoughts on what would be optimal between covers?
So assuming we're talking about within a given cycle rather than within a day here, it really will depend on, you can sort of base it off of what the general expected longevity of semen will be in the mare's reproductive tract, knowing that not every stallion is going to follow those rules. But I think the biggest thing about timing and how often you would want to breed depends on what your mare is doing and when you expect her to ovulate. So my rule of thumb, sort of in general, would be that the semen should be no more than 48 hours old by the time the mare ovulates. So it depends when you give your ovulatory induction drugs, but rarely would we be breeding more often than every other day. Because you want to give yourself, you still have that 48-hour period then if you do it every other day for ovulation to happen between two covers.
Dr. King, can you speak to the use of PRP in breeding of aged mares?
So I like to use PRP when I'm expecting the mare to have problems with fluid retention. There's some work that was done that shows that it decreases the amount of inflammatory reaction you have when you administer it before breeding. And some people feel like it also helps to tone the uterus for those cases that we were talking about where their lymphatic drainage is very good, that it improves the tone of that uterus and helps it to respond to fluid in a little bit more coordinated and effective fashion. So for me, I like to use it between 24 hours and 6 hours before breeding. There are some people who are using it after breeding, but to me, I feel like by then they've already gotten a fluid reaction at that point. So I like to do it preemptively before that. And actually, I think Dr. Pash worked on some of this during her residency, so maybe she could speak more to that.
Yeah, I think that I also find it most useful in cases of delayed fluid clearance. And usually those are mares that are having that kind of excessive inflammatory reaction to the semen. But agree with giving it beforehand. And the thought behind that is that if we can stop the inflammatory cascade before it really gets going, it's going to be more effective. So I like to give it in that same kind of time period. Sometimes I'll go out even a little bit farther, between 48 and 24 hours before we inseminate the mare. So that we're not really trying to just put a Band-Aid on the problem once it's already gotten started, but we can hopefully prevent it from getting to a bad point altogether.
Are there any risks associated with the biothermal microchip?
Not that I've heard.
Not anymore in my mind than
we've been using it lots, and
a regular microchip.
Yeah. It's awesome. Wondering if you should do it.
Oh yeah, go ahead.
Do you always give oxytocin after insemination, or are you only using it with mares that tend to retain fluid?
Oh yeah, I like that question.
Big question. I think most of us are pretty liberal with oxytocin use. If we have any reason to suspect that that mare is going to have trouble clearing fluid, then we're pretty quick to use it. It's easy to do. It's super cheap. So why not? It's sort of the thought, at least once 6 hours after breeding. But having said that, I don't use it in every single case. If I have a young mare between 3 and 10 and I have no reason to believe she's ever going to have a problem, I don't use it in those cases.
I like oxytocin always.
Fair enough.
I'm one of those people that I feel like, I guess, even in young mares, I will recommend at least a single dose of oxytocin post-breeding because it's cheap. And I'm not going to ever, I mean, yeah, there are some times when I'm advocating for somebody to go like in the middle of the night and give a shot, but like mostly I don't want people to get up at 3 a.m. to give oxytocin.
The worst, yeah.
Compliance is not good.
But the worst feeling is to come back at the OB check when you didn't give oxytocin and have a mare full of fluid. You're like, well, that was like a 2-cent shot that I could have given and I didn't do it. And now we're behind the 8 ball.
Yeah, oxytocin's cheap. That's my feeling. What do you think, Dr. Pash?
I use it less regularly than I used to. And I think that's very case dependent. I'm definitely less likely to reach for oxytocin in a thoroughbred who has just been bred live cover. We've confirmed that her cervix is relaxed and she's getting turned out into a field to run around with another group of mares. So I think management plays into it, and that's a very different scenario than, you know, whether she's old or not, but a mare bred with frozen semen in a clinic who is then standing in a stall. So it's rarely wrong to give oxytocin post-breeding in the correct time period. But I try not to use it when I don't think it's necessary.
Talk about your oxytocin recommendations in the post-foaling mare.
I tend to use little tiny baby doses of oxytocin in post-foaling mares. The reason for that is they have a pretty significant upregulation of those oxytocin receptors in their uterus as part of foaling, because that's a big part of what is actually working to contract the uterus and help push the foal out. So whereas in a post-breeding mare, I might give her 20 units or 1 ml of oxytocin IM. In a mare who's immediately postpartum and has, for instance, retained fetal membranes or a sick foal and she's in a stall, I personally tend to start pretty low at about 1/4 ml or 5 units IM. I don't like to give it more often than every 4 to 6 hours because of that kind of spasmic contraction that Dr. King talked about. And so I guess my main takeaway, there's a big range in how different mares respond and different doses people use. But for me, I like to start low, knowing I can always add more.
I agree. I use low doses in post-foaling mares because usually they colic if we go higher than 0.3 to 0.5 cc's.
Yeah, I especially like to recommend it if there's some reason that the mare can't be turned out. You know, if it's like weather related or foal related, like a rib fracture or something like that, I'd like to try to help the mare. But yeah, we're really careful about how much.
And I think just one other point on that is if the mare has a healthy live foal by her side, every time that foal nurses, it's providing an endogenous oxytocin. And that's way better than anything we're going to be able to give her. Which really speaks, I guess, more to mares that don't have a live foal or don't have a foal that's able to nurse are going to benefit more from some exogenous oxytocin.
Rhino vaccines. Is it a good idea to vaccinate all the horses with some, I think in this situation, they're talking specifically about prodigy, sharing pastures with brood mares at 5, 7, and 9 months. So do you recommend vaccinating any horses that are sharing a pasture with a brood mare at 5, 7, and 9 months gestation?
So ideally, yes, because we're going to decrease that incidence of viral shedding. So in the instance where we may have a recrudescence, the viral shedding can be much, much less if they've been vaccinated on that same protocol.
And that also speaks to the question that they asked about whether it is brought in from new horses only, or in that situation, you're talking about it being present in the herd that you have.
Correct. If you've got an adult herd, probably 100% of them are carrying herpes virus or rhinovirus.
Would someone like to talk about biofilm and the older mare?
Sure. Biofilm, I wouldn't say is something unique to older mares. It can happen with any aged mare with a uterine infection. It's a huge topic. I think maybe next year we should make it a topic of discussion because I could go on about it all day, but it's associated with usually with gram-negative infections and yeast. The bacteria form a protective coating on top of themselves so that they're very difficult to remove from the uterus. And so what we find is we'll treat those mares with antibiotics or lavages, and then things will look okay, and then the infection will come back, or sometimes there'll be a different bacteria that will culture the next time. And so there are a lot of protocols out there for destroying that biofilm, breaking it up so that we can get access to the bacteria that are sort of stuck to the uterine wall and removing them. It's sort of the general overview of it, but there's a lot more that I could talk about with it. But yeah, I wouldn't say it's necessarily an age-related change.
Your sensitive broodmare. Is there any point in a situation where a mare's a mare overreacts to vaccination, that might outweigh the potential benefit of giving a rhino vaccine at 5, 7, and 9 months and pre-foaling vaccines. So for example, a mare that is prone to uveitis or a mare that overreacts and spikes a pretty high fever to vaccines.
So yes, in my mind, absolutely. We always got to weigh the benefits to the risks. And if the risk to the mare is greater from vaccination than from incidence of disease, and I'm going to forego vaccination, try to keep that horse as isolated as possible to protect them, keep their stress level down. But if vaccination is a traumatic event for them, then by all means, I'm going to take them out of that protocol.
I would say that for me, I would try to figure out if there was a particular vaccine that they were reacting to more, because I care so much about the passive transfer and the quality of the colostrum. Like, you have to start to think about, you know, is the priority here for the comfort of the mare, or are we worried about the future health of the foal? And you have to balance that. And so, yeah.
In that case, I would probably have a talk with the owner about, you know, plasma administration for that foal if the mare was not able to be vaccinated, just so that we got that immunity as high.
Yeah, I agree. I mean, I would try to change to a different brand or a different adjuvant at least, to see if we can minimize the reaction. I also don't have a problem pre-treating them with Banamine, and while it may diminish, I don't like doing that as a general rule, it may diminish their immune response. You can certainly jump in, but to me, even if you're getting, especially in that pre-foaling situation, like even if you're getting some increase in immunity, even if it's not 100% what it would have been, but you're preventing that mare from having a fever and possibly porting the foal, then I would pre-treat first.
So Dr. Jabsikas, in a specific mare, foals have become ill with R. equi 3 years in a row now, and none others on the farm. Would considering giving plasma against R. equi make sense? Particularly for that mare's foals?
Yes, it would. So I think that there definitely are mares that have foals every year that have rotococcus. And the thought is that that's probably because of their genetics that they're passing on, not so much any strain of rotococcus that they're passing on. But I would definitely think that even if you're not doing plasma for all your foals, that would be a good place to spend your money.
I've got a question here about recips. What would be your course of action when using a 20-year-old brood mare as a recip mare? Let's start with that question.
I would advise against using a 20-year-old. You know, all the things that we talked about today, all of those age-related changes, by the time those mares reach 20 years old, they're probably pretty significant. If you were dead set on it, I would say at least get a biopsy to make sure that she's even capable of carrying a foal to term. But, you know, there's a lot of expense and effort that goes into retrieving embryos and transferring them. And so I think that would be a big gamble. I don't know if you have.
I would not use a 20-year-old recip, period.
Save her for a nurse.
Yeah, or
she can have other jobs.
More commonly, we see 20-year-olds as donors, not as recipients. And I mean, did you say what your cutoff is in age for a recipient?
Me, I like them to be 13 and under. I will consider slightly older than that if somebody really, you know, if that's what they really want. And I've explained all of the downsides to that, but 20 years old is far beyond what I would do.
Yeah, I think I'll go into the sort of the mid-teens in particular cases. Like, I agree, under 12 and 13 is going to be ideal. There are some areas that are a little bit older that I think work as recips if they've proven themselves. That it's a mare that gets an embryo transferred into her every year. She takes first try, she keeps it, she foals without complication, you know, and does not have any problems. That's a mare that maybe I would use into for mid-teens, but certainly not into the 20s.
How do you diagnose endometriosis, or I'm sorry, endometriosis? Endometriosis.
So usually with the biopsy, when we look at the biopsy, we're looking at gland density, we're looking at the amount of fibrotic changes that are there in the around the glands, around the blood vessels. We're looking at the lymphatics and whether or not they're dilated. And then I did put it in the talk there. There's also, if you look at them hysteroscopically, sometimes you can get an idea of some of those changes that are happening, but the biopsy is really going to be the gold standard for diagnosis. And it's really, I think a lot of people feel like it's invasive, but it really isn't. It's something that we can do standing on the farm. It takes a second. It only takes a very tiny bit of tissue out of the uterus. The mare doesn't really have nerve endings in the endometrium, so she doesn't even notice when you take the sample. It's easy to do.
Here's a question about foals and diarrhea when they're getting their gut flora established. Do you have any, Dr. Javsikas, can you make any recommendations on ways to support foals when that is taking place to maybe minimize diarrhea? You're welcome.
There's really nothing that's proven. So someday we may understand how to manipulate the flora of the foal and adult horse. Right now, what we know is that the balance of organisms is really important and contributes to diarrhea in foals and adults, but we really don't know how to manipulate it successfully. So you can try pre and probiotics. Most of them are very safe, but they may not help. And I say most of them because there was actually a study done looking at foals with diarrhea with probiotic, and it actually made the diarrhea worse. So I think just maintain the best thing to do is make sure that the foal is otherwise healthy, had good IgG at birth, that the mare is on a good diet, that there's high quality food, and to basically try to support that foal to make its own healthy. There's no magic, sorry.
Darn it. Okay, so this question goes to our theriodonologist. How long should a mare remain on Regimate during their pregnancy?
Another big question.
You're welcome again.
Well, it depends what you're trying to accomplish with the Regimate. It depends, period. Yeah. So after placentation starts at 40 days, it's usually completed by 120 days. So some people will use that 120-day mark as a cutoff. Some people will use the 40-day mark as a cutoff, or some people will go to 60 days thinking that, well, by then the placenta is well on its way to being established. And so we can stop using extra progesterone at that point. If you're using it for a high-risk pregnancy mare, such as a mare with placentitis, usually we'll take those mares on Regimate almost all the way up to foaling, taking them off when they get really close to foaling time. And then some people will leave them on it and then do a progesterone test at 14 days. And if the progesterone looks good, then they'll take them off. But I think it really depends on the individual mare and the reasons that we're putting them on the Regimate in the first place. So it would kind of be taken as a case-by-case basis if there was a good reason for using the Regimate in the first place, which there often isn't. I think a lot of times mares just go on Regimate because why not?
You guys can answer this question for me. What would you consider, which mare would be a good candidate for short cycling? And you're allowed to disagree with me if you were like, no, I think your Mythbuster was stupid.
So I don't hesitate to short cycle mares if it's going to, we're very often short cycling mares because it's going to make it, I don't even want to say easier, it's going to make it possible and more practical to actually inseminate her and get all of our timing squared away. But as Miranda said this morning, those mares should be ultrasounded before we short cycle them, ideally. But the big time points to keep in mind for me would be that CL isn't going to respond reliably until at least 5 days. And that also the size of your follicles at the time you give prostaglandin is going to have a huge effect on what happens afterwards. And so, again, it depends. But I think keeping in mind those two things, where the mare is at in her cycle, what her follicular size is, and how old the CL is at the time.
So when you're choosing a short cycle of mare, I'm just thinking about like what you're expecting to see on the ultrasound, right? Clearly the mare can't be in heat. That would be a no-go. I mean, I guess actually we could talk about using the use of prostaglandin as an embolic, like just to muddy the water a little bit. But do you like to use estromate at all in the place of oxytocin sometimes, or what are your thoughts on that?
I personally don't do that very often, for a couple of reasons. One being that I find, I guess I don't really know because I'm not inside the mare's uterus, but I feel like estromate, that'd be fun. Get weird. Estromate.
It'll be next year's gift.
Coming back to that, like, the spasmic contractions that happen if you give a big dose of oxytocin is more what I think, in my experience, that's more likely to happen with prostaglandin. So I get less of the kind of controlled, like wave-like contractions that are going to push fluid out, and more of just like a tonic, like kind of spasmic contraction. The other thing is I don't find it to be that useful. But I think the most important thing is to remember, if you are using estromate for fluid clearance, if you do it post-ovulation, you are going to affect the quality of that newly forming CL, if that makes sense. So if you use it before ovulation, fine, go for it. It's going to potentially help clear fluid. But if mares are treated with estromate or Lutalize for fluid clearance, the day of ovulation or later, those mares should go on Regimate before their preg check, in my opinion.
I find it useful in some cases if they're not responding very well to oxytocin. I find that switching to propranolol, sometimes in a little bit of a lower dose than you would use for short cycling, can sometimes be helpful. It also, I like it if no one's going to be able to give that mare any injections like overnight or something. It tends to have a bit of a longer duration of action, so somebody can give it just before bed, and then they don't have to worry about giving the oxytocin as frequently. But yeah, absolutely, I agree with the CL comment that I won't use it after ovulation at all.
So hopefully we answered all the questions about short cycling and the use of propranolol. Would you choose to breed an older mare on the full heat?
Choose to.
How might you select whether, are there criteria that an older mare needs to meet in order for you to consider breeding her on the full heat? How's that better? Okay.
So there's a lot of factors that go into that decision to me. One of them is how accessible is the stallion? So, if we try and fail, is that a big deal? If we're using a single straw of a very important dead stallion, then definitely no. The stallion lives on the farm, and sure, give it a whirl, why not? But in general, I find those mares, the older mares, tend to involute their uteruses more slowly. They take a little longer to recover from foaling. And so I consider breeding on full heat a little more carefully than I would in a younger mare, for sure. Do you have anything to add?
Yeah, I similarly don't love to breed on full heat as a regular course of action. Just because I do find that and I think the literature reflects this, but clinically too, I see more pregnancy loss at, the 40-day check, the 45-day check. And if that mare already has endometrial cups, then you're done for the season. If I'm going to breed on full heat, the mare has to meet a number of criteria, which I think are harder for older mares to meet, but it needs to be a textbook foaling with no significant trauma, no retained placenta. That mare should have cleared all of her fluid by at least 7 days postpartum, and I don't want her to ovulate any sooner than 10 days. all of those factors just kind of combine to give us the best chance of getting a pregnancy. And I think, like you said, the older mares are more likely going to take a little bit longer to involute and recover. And I think they typically benefit from another cycle under the belt.
Most of the time, I find those mares don't pass the criteria that you just gave. They usually have
That makes it easy for you.
Yeah.
And do you have any techniques for attempting to delay the full heat? Okay, so that would be a no.
There was some data that was published a while ago now, but that was showing if you gave, was it estrogen and progesterone on the first day after foaling, that you could delay it, but they then found that those weren't very fertile cycles, so it's a very good idea.
So short answer, no.
No. Is there anything that you recommend that could potentially help a mare when you are breeding on the full heat?
I think making sure that they've doing everything you can to ensure that they meet those criteria of a textbook foaling, no retained placental fluid clearance. So whether that's ensuring that they have a healthy foal that's nursing, making sure they get turned out, maybe those are mares that need oxytocin, but doing everything you can to just kind of support the uterine health in that time period.
Yeah, I think turning them out is a major factor in that, and it really helps uterine involution.
I think the question on here about biothermal microchips in foals, do they work for temperature monitoring for the entire lifetime of the horse? My understanding is yes.
Sure.
I think probably the only challenges that we have with our using the biothermals is that I think you have to look at what the normal is for the horse. And depending on the placement of the chip, if it's a little bit too superficial, sometimes it will not be an accurate representation of the body temperature. And so what you're really looking for in that situation is what the change is relative to the other times you've scanned. Do you guys have any other recommendations on that?
I think just when you're first getting used to using them, comparing it to the rectal temperature is useful because they do read a little hotter than a rectal temperature. So if you're used to seeing those kinds of numbers, you might be alarmed at first at the numbers that you're getting on the chip, but they're normal.
Yeah, we tell people to watch the trend. So anything that goes outside the normal trend, of course, is been microchipped. Need to verify that temperature.
Rectally.
Yeah.
The question.
Yeah. So we were just talking about stallions with, I think, what we can describe as really, really good libido. So good that you have very little time between them seeing the mare entering the breeding shed and being like fully erect, belled up, ready to ejaculate. And so I think with those stallions, finding a way to get them to focus on the task at hand, maybe take the edge off. So drugs can be our friend in that scenario. I like to use Valium or midazolam, any of the benzodiazepines in stallions at small doses, because I find it does help take the edge off, but it doesn't make them sedate. I don't worry about ataxia, and it feels much safer than giving something like xylazine, where I'm like, they're standing on their hind limbs with us. We don't really know how they're going to react. So I think aside from different management techniques, which would be like with stallions like that, we'll wash them in the stall outside of the shed, and then it's like you open the doors and they're ready to go. But I think adding Valium, midazolam, one of those drugs, can be very useful in helping them kind of calm down and realize what they're supposed to be doing.
What about something like tramadol? Trazodone? Oh, that's what I meant. Yeah, sorry. No.
I haven't used trazodone in breeding stallions. I imagine it would be just like it always is, very stallion dependent. And so you'd have to play around with the dose, I think, and it would be very individual what that would do for them. I also don't know how that might affect their libido, for better or worse.
Yeah, so deslorelin and hysterelin are both ovulatory agents. So they stimulate the pituitary gland to produce that LH that we were talking about earlier that induces ovulation. And the idea is that we only use them once the follicle is mature and has LH receptors. So that means that the oocyte that's inside is ready to ovulate. But we give that LH surge with these agents artificially a little bit on the early side so we can predict exactly when she's going to ovulate rather than trying to figure out when she's going to do it on her own. And the advantage for these older mares that need a lot of extra treatments and, you know, monitoring for breeding them effectively is that we know when they'll ovulate. We know when we can breed them just the one time. So we minimize breeding reactions and things like that. So we can get the timing just perfect on them. And also because they're usually subfertile in the first place, breeding them closer to ovulation is usually a bit more effective. Deslorelin there's an FDA approved product, so we use that quite a bit. Hystrelin is a compounded drug, which is similar to Deslorelin.
Are there any supplements that you can recommend to help a mare that has history of retaining her placenta over the last 2 pregnancies? It's a young mare, but is there anything that you recommend to try to prevent retention of placentas proactively?
I think there's been some discussion about whether or not like vitamin E supplementation and things like that can help. I don't know that anyone's ever proven a link between them. Certainly good nutrition. They're on a good commercial diet that has all the right balance of vitamins and minerals. That should, now I don't know that there's much more than that we can do. There are platinum supplements to make sure that they're getting all those nutrients in the correct ratios. But otherwise, I don't think there's anything for sure that's like a treatment for that, unless you know of anything.
No, I think it's, you know, like you said, the good general health for the mare. And they're just like there are certain breeds that are more predisposed to retain placentas. There are certainly individual mares that do that year after year. And I found the best thing we can do is just expect it to happen and treat immediately. But yeah, if there is something we can give them ahead of time to help fix it, that'd be great.
In our area, do you guys routinely recommend vitamin E in pregnant mares? Or do you recommend foals receive vitamin E or selenium at the time of birth or soon thereafter?
I routinely supplement foals with vitamin E selenium at birth.
Me too. Yeah. In our area, it's supposed to be deficient at least in vitamin E for sure. So I think it's helpful. I have one more thing that I would like to ask you on behalf of many clients who asked this question of me. But can you give your recommendations for strangles vaccination in terms of passive immunity, protecting mares on the farm from strangles that might be coming in, and protecting foals?
We do not have a strangle vaccine in our portfolio, so I don't really have a dog in the hunt.
Okay.
And where I come from is kind of the capital of crazy strangles.
Yeah.
So I can tell you nothing seems to work very well. You know, it's mostly a biosecurity and getting the herd cleaned up and making sure you don't have carriers and those type of things, because exposure leads to clinical disease almost always. I haven't found anything that works great. I don't know, Dr.
Do you have any opinion, Dr. Tipsy?
I mean, I think the IM vaccine is better from a passive immunity standpoint to get to the foals. Whether or not you need that on your farm may or may not, I think depends on the farm and the incidence of strangles in the area. I think quarantine and testing is the way to go. So ideally, I know it's hard, but it's getting easier, right? I mean, we can now do PCRs in our lab. So
well, it's almost impossible on a breeding farm if you have mares coming for breeding and then leaving multiple times a day.
So but then in that case, I think the like biosecurity in the breeding shed is important too. Like how exposed are they getting to other horses while they're there, and what are they blowing their nose on and all those things. So it's really, it's a pain and it's expensive to do the testing, but if it shuts down your program mid breeding season, that's even more expensive.
So do you think the IM vaccine is valuable at all?
I do. Yeah. And I have to say we have a large breeding farm that's been using it for years, and so the main downside to the IM is thought to be local reactions to it in the muscle, and their incidence of problems is very, very low, like
minuscule.
I did jinx it though, because I asked the manager this fall how many problems he had, and then he sent me a picture a week later. But I think overall it's very, very low that they have a problem with it. So
I've got one more question. I know. Well, everybody was leaving. Would you ever use Regimate to postpone the full heat?
No.
No.
I think the mares have at that time, it's really important for their cervix to be open and their uterus to be contracting and getting rid of all of that foaling goo stuff. And so when you give them Regimate, that depresses all of those functions. And so I think you're doing the mare a disservice to give her Regimate at that time.
Think it will affect her fertility
in the wrong direction.
Yeah, it won't help in that situation.
So the question is about deworming, when to start deworming foals and whether or not to deworm mares when they foal. So deworming them when they foal with an ivermectin product was recommended for strongyloides, which is transmitted in the milk. We really don't see clinical issues with strongyloides at all. So I don't think that it is important to do. Some people do find it to be a convenient time to deworm that mare to make sure that they are dewormed that year. So if they're getting, I recommend that they get a product like Equimax in the winter in our region. So it's something that has ivermectin and praziquantel, because you're going to get tapeworms with that. Most horses, healthy horses with good immunity, once a year is what they need for that. So I prefer they get that in the winter and then not worry about when they foal and if they're getting dewormed then or not. Full deworming, that's an entire lecture in and of itself. It really depends on the farm. And again, resistance is a huge, huge problem. The worms don't really mature to the point to cause an issue until the foal is about 2 months old. That's based on the life cycle of ascarids, which is what we worry about in that age group. But you really have to know what products work on your farm. And again, we really need to be really smart about what products we use, because we have even fewer options with deworming compared to antibiotics. So I live in fear of, I think those are the things that are going to kill all of us.
Yeah, do fecals.
Yeah, routine fecals, pre and post deworming in a subset of foals. I have a whole protocol for what population, what percentage should be tested and things like that. But it's really important to know what's happening on your farm, and also to think about foals coming into your farm from other places that may be bringing their resistant ascarids with them.
And I will make a point on ascarids, which we're seeing resistance increase widespread across the country. Make sure if you're using Safeguard or Panicure, the fenbendazoles, which are the most effective against ascarids at this point, that you do use a 10 milligram per kilogram dose. So it's double the dose you would use in an adult. Because if you don't use that dose, you're not going to have an effective kill.
Do you want to say, if you're looking for help on deciding what the deworming protocol is, this is just like a rough guideline. There are wheels over there at the Merck Animal Health table. On one side, it has full care, and on the other side, it has pregnant mare care. And I probably use that every month. Like, I look at it regularly just to even to figure out like what the due date is on a mare. It's a really helpful tool. So please grab one of those.